Coordination of work under the umbrella of Violence and Mental Health South Asia, that's VAMSA. And you will hear more about it as we go from the representatives of different parts of the collaborative. What we will see today is the result of work done over 4 years by a multi-country team which has brought in its expertise and experience of many, many years of work and of many disciplines of work as well. So the dissemination today is of a package of care. It's a comprehensive package that aims to address the mental health needs of women, survivors of violence, of modern slavery and civil conflict. And it has been developed drawing upon work in India, in Sri Lanka, and in Afghanistan. As we all know, violence against women is common and is often invisible. It is also strongly associated with short and long-term mental illness. The relationship between violence and mental illness is multidirectional, it is complex, and it needs patient and appropriate handling. We are hoping that the package will provide meaningful and feasible pathways to counselors and to service providers to be able to address this complex of survivors' needs. Following today's event is a 2-day symposium on gender-based violence and mental health research, which brings together researchers and scholars to exchange their experiences and research findings at the intersection of mental health and gender-based violence. And the hope is that it will help lay a platform, a ground for future work at this intersection. To begin the day, I would like to call upon Vanessa D'Souza. She's the Chief Executive of SNEHA, to come to the dais and to tell us more about the organization's commitment to mental health and violence integrated across all its programs. I'll briefly introduce Vanessa for those of you who don't know her. She has served as Chief Executive of SNEHA since March 2013 after a volunteering stint with the organization. Prior to that, she worked with Citibank India in various positions and various roles. She has many feathers in her cap across the corporate and social sectors, and she has pursued a continuing learning curve through programs like the Strategic Perspectives in Nonprofit Management at Harvard Business School. Over to you.
Thank you, Rukmani. Good morning, everyone, and welcome to this morning. I think it's 4 years of hard work by an international team, and a lot of thought has gone into this. And I really thank all of you for coming here, especially those who've come from outside of Mumbai or outside of India. I just want to give you a brief introduction to the work we do at SNEHA. And in my presentation today, I'm going to specifically focus on gender-based violence and mental health, which we see at the intersection of all the interventions that we do. SNEHA, as many of you know, was started by Dr. Fernandez, who's sitting on the front row over here, a neonatologist and former dean of Sion Hospital. And as Dr. Fernandez practiced at Sion Hospital, she saw a lot of women delivering babies that were 700, 800 grams, some of whom survived, some didn't. And many of the ones that survived ended up having physical, mental challenges. The other thing she saw during her tenure at Sion Hospital was women experiencing domestic violence. And so when she retired in 1999, she established SNEHA and started working with pregnant women to help them deliver healthy babies so that every child had an opportunity to be born healthy right from the start. And also working on domestic violence. Now, mind you, this was 1999, where words like gender, gender diversity, gender-based violence were pretty much unknown, and unspoken of, rather, in a country like India. Today, when we, and therefore, can I use, yeah. And she started SNEHA with the vision of building a healthy urban world for women and children. The founding team, being from the public health system, believed very strongly in working in partnership with the public health system to really bring about sustainable change at scale. And therefore, our mission was to work in partnership with public systems and with vulnerable communities to improve health outcomes and empower women and their families to have better health and to seek better health. SNEHA works on a continuum of care approach to break the intergeneration cycle of poor health. And we work at every critical point in the life cycle: pregnancy, at birth, with young children, adolescents, and of course in adulthood. And an underlying theme in all our interventions is gender, gender-based violence, and mental health at the intersection of gender-based violence. Our 4 pillar programs are maternal and child health, adolescent health, prevention of violence against women and children, and public system partnership. So where do we work? If you look at a map on the left, that's the Greater Mumbai region. We work in 7 municipal corporations in the Greater Mumbai region. And this is what we call our laboratory. This is where we build evidence-based models of maternal, child health, adolescent health, and gender-based violence. We work with 181 health facilities and 416 ICDS Anganwadis, and directly work with 122,000 households, reaching a population of a little over 1 million in these 7 municipal corporations. In the last few years, we have also been scaling our work in partnership with other NGOs as well as with the public health system to create impact as technical partners to create impact in other parts of India as well. I'm going to very, very briefly run you through a snapshot of our programs, and I'm going to mainly focus on the work that we do on gender-based violence and mental health. Our first program is the Public System Partnership Program, where our objective is to improve health and nutrition systems, public systems, to provide better quality services to women and children living in vulnerable, informal urban settlements. We do this 3 ways. One is to strengthen the primary care services at the health posts and at the Anganwadis. We also do it through establishment of a maternity referral network, which we have established across 7 municipal corporations, so that high-risk women in labor can reach the appropriate health facilities and get the appropriate services, thus saving lives of both mothers and children. When we started working with primary care facilities at the government health posts, there was absolutely no antenatal care services, available. And today, 99% of the health posts in our intervention areas are providing antenatal care services to pregnant women. If we look at the maternity referral networks, this is an innovative model that was established by SNEHA and the founding team and people like Dr. Fernandez, Dr. Shanti Pantvadya, Executive Director, and a couple of our associate program directors and program directors were very instrumental in actually establishing the system. And what it tries to do is it creates a referral system between different levels of the multi-tier health facilities in these 7 cities, so that women who are in labor and also in high risk can reach the appropriate facility on time. We've established 12 intra-region or intra-city linkages and 7 intercity linkages. And you can see we've been able to actually support over 48,000 can reach the appropriate facility through this maternity We've established system, 12 saving lives of mothers intra-region or intra-city these are all linkages and 7 intercity linkages. Our next program is the Maternal and Child Health Program, and this is an integrated approach where we work with preconception care, on family planning, on anemia, on reproductive health. We work through the period of pregnancy with children 0 to 6, but with specific focus on 0 to 2, because we all know that the golden period, the first 1,000 days, is pregnancy to 2 years of age. We work with adolescents as well as on gender-based violence and mental health. We run this program in 4 large community programs in these 7 cities. And we work with 122,000 households in these and over 22,000 children aged 0 to 6. So what's the kind of impact that we've created over here? I've only put in 2 or 3 slides for impact, and I think the most critical impact for us is addressing malnutrition in children. The slide you see here is the baseline to end line of one of our programs, which is the SNEHA Center program run in the M-East wards of Mumbai, which we know are extremely vulnerable wards. And here you can see that we work on all three forms of malnutrition: stunting, wasting, and underweight. Now, 2019 to 22, as we know, is also the pandemic period. But despite all the challenges of the pandemic, the team was able to reduce stunting by 27%, from 37 to 27%. Wasting remained flat at 12%, but underweight we were able to reduce by 17%. The next important aspect of this work, and I shared with you in our mission, a very important work is strengthening public health systems. In this program, we measure the uptake of health services through the health post, through the municipal corporations, and the nutrition services through the ICDS Anganwadis. And here too, you can see there's been a 70% increase in uptake of health services and 132% increase of nutrition services. And for us, this is extremely important because when the uptake of services increases, we know that then we are able to sustain change. We know that the communities are aware of the services, and even going forward, they will continue to access these services. This is a very interesting slide. And this is a slide where we've tried to understand the impact of violence on other indicators of maternal and child health. So this is a sample of 345 women in the vulnerable P North ward of Mumbai, taken between April to December 21. 345 women accessed the counselling centers, of which 239 women were also availing of other kinds of services from SNEHA. Could have been family planning, it could have been births, during working through pregnancy, or even malnutrition in children. If you look at the column of matched, these are women who are accessing the counseling services. And if you look at the intervention, these are women where we have not identified violence. Let's look at the first indicator, which is uptake of modern methods of family planning. Only 18% of the women were empowered enough or capable, or it was possible, had enough agency to actually adopt family planning, compared to 48% from women who were not experiencing violence. Similarly, if you look at anemia, the prevalence of anemia was higher where women are experiencing violence compared to women not experiencing violence. Let's look at the two indicators of malnutrition, stunting and wasting. 55% of children whose mothers experienced violence are stunted, compared to 37% of women not experiencing violence. And similarly, underweight, you see a 42% compared to 27% of women not experiencing violence. And I think this, when we looked at this data, I think it really reinforced our belief that though we work with mothers and children on health, it is so important to work on the underlying issue of gender-based violence and mental health. And like Rukmini said, we all know that gender-based violence is a silent disease. And it's silent, and it's also intersectional, and it affects other aspects of life. The next program we will talk about is Empowerment, Health and Sexuality for Adolescents. This is a program that works with young people on physical health, reproductive, building emotional resilience, building change agents in the community. And we also work on mental health in this age group. We have this cohort, we have about 4,000 children that we're working with, and we work in schools as well as in the communities that we cover. Again here, I've picked up just one indicator, which is mental health, because it's relevant to this conference. And I want to share with you a cohort from Jan to June 22. Interestingly, what we've done in this program is we've trained to screen for mental health. And you can see here 918 children have been screened by our community organizers, of which 374 have been identified as red flags. Now, red flags don't necessarily mean any kind of mental health problem, or a moderate or a medium or a severe mental health problem, it could also mean certain stressors at that point of their life. So it could be exam stress, it could be relationship stress, and in the pandemic, we saw a lot of stress related to loss of jobs by the parents. So, income, family income stressors. If you look at the box on the right, of these 374 children, 284 children have actually been observed or been worked with clinical psychologists, and 135 of them have been identified for further therapy or psychosocial support. So overall in this cohort, we saw that 14.7% of children actually need some form of intervention for mental health. Now we also know that it's very, very critical to work with young people on mental health so that we don't have more severe manifestations of mental health later as adults. The next program is prevention of violence against women and children. And I'm going to spend a little more time on this program because this is really core to this event of today. This is a program where we work with communities as well as with public health systems on prevention and addressal of gender-based violence, working at multiple levels, at the individual level, the household level, the community level, and of course working with public systems and for policy change. In the period 2016 to 22, we had over 23,000 women who accessed our counseling services, and 76% of these women reported reduction in gender-based violence. So what is this model? This may look very confusing, but this is the socio-ecologic model that we have adopted because we know that violence is an intersectional issue and requires us to work at the individual level, at the family, the community level, as well as work with public systems, and of course, work on advocacy and policy change. And therefore, there are three components of our model. The first is primary prevention, and this is where we create awareness in the communities that we serve on gender norms, attitudes, beliefs, practices, to try and eventually bring about and create an enabling environment where there is zero tolerance to violence. At the secondary level, we work on providing crisis intervention and counseling, and this is done through counseling centers within our communities, at the public hospitals. So we have counseling centers at Nair and Sion Hospital, and we have the one-stop center at the KEM Hospital, where SNEHA is appointed as the implementing agency on behalf of the Department of Women and Child Development. And the third aspect is the tertiary prevention, where we look at building institutional capacity, the police, the health systems, the legal systems, and of course addressing mental health at the intersection of violence. Let's look at some data. During the pandemic, we all heard about gender-based violence and the increase in violence in households. And I think as SNEHA, and I'm sure most of you working on the aspect of gender-based violence, felt pretty helpless during this period. During the pandemic, actually, we moved overnight to phone counseling, online counseling, and of course, our one-stop center was running 24/7 right through the pandemic period. And this, in a way, enabled us to address gender-based violence to a great extent in our communities. So if you look at the period 2018-19 and 19-20, you'll see a 53% increase of cases that came to our counseling center. And during the pandemic period, while there is an absolute increase in cases of violence, we actually see in percentage terms it was less. And we all know why that happened. Is because most often the survivors were locked in with the perpetrator, and many of the physical spaces, the counseling centers within the communities were shut. Many of them were not capable or not aware of some of the online services that were counseling services. And our teams did a lot of work to provide this information to the communities through ration packs and putting up the counseling helplines at different points of service that women accessed. We look at the counseling outcomes at 2 months. So this is now women who have availed of counseling services, and we evaluate this at the end of 2 months. And you can see 88% of women said that they did have reduction in violence. Is my time up? No, okay. We can see 22% of them actually reconciled, which we know in India is also very important. Most women want to reconcile, and we do encourage them if it's their preference. But 30% of them chose to move away from the violent situation, either to their natal family or move it out independently. And about 9% of them were able to avail of their Sridan, which as we know is the assets that women receive on birth, on marriage, or on widowhood. If we look at the mental health indicators of women who've accessed counseling services, again, we can see improvements in depression and anxiety. We see a moderate improvement in coping abilities, and that's also because women do take time to build their coping abilities, both social abilities, mobility, etc., and of course, their well-being. This is our work with the public system. So we've covered the secondary, this is the tertiary level intervention where we work with the public systems. So this, the one-stop center, actually we started working in September 2019, and you can see we've done over 1,200 survivors of violence here. We've also do a lot of training of doctors, nurses, and staff of public health systems to identify and refer cases of gender-based violence to counseling centers, to helplines, because we don't want that woman to go back to the same situation that she was in before she reached the hospital. So these are typically women who've experienced fractures, burns, sexual violence, who then need to avail of counseling services. We've also trained police in the Mumbai police and sensitized them so that when women access the police, they are able to get adequate services in a very sensitive manner. And of course, we work with the district legal aid to provide legal help services to our survivors of violence. This program of social protection was started during the pandemic. So in the month of May, June 2020, we knew that lots was changing in our communities, and we wanted to determine what were these new and emerging needs in the communities. And I think two things stood out very strongly. The first was loss of wages. And while SNEHA as an organization doesn't work on livelihood, we thought it was important for us to then begin to work on social protection so that women could avail of their entitlements. And the second aspect that came out very strongly in the pandemic was the need for health information related to COVID. And therefore, all our programs, we layered with social protection as well as COVID. And by the way, we also layered it with mental health because we did see lots of stressors in our community, not necessarily domestic violence, but all kinds of mental health issues. So what we did was, we know that there are over 280 government schemes. So we chose schemes that were related to the target groups that and I won't run through the schemes, but I did want to tell you that, we chose them to target groups that we work with. And we work, again, using our community volunteers, community action groups, building awareness of these schemes. And actually, there are three things we do. One is to build awareness. Very often, awareness is the first step, that these schemes are available and communities are entitled. The second is to refer them at that appropriate time, to refer them to the various schemes. And the third, the most important, and as we know, the most difficult, is the uptake of schemes. So helping them with documentation, and very importantly, helping them establish linkages with the public system. So whether it's the public distribution system, it's the health posts, it's the Anganwadis, providing that linkage and helping them to learn and build their capacity to access these services. The last program, it's not linked to the continuum of care approach, but the reason I put this in is because this is also a program where we provide counseling facilities. Palliative care is, the Romila Palliative Care is a program we started very recently, actually spearheaded by our founder in 2017. And it provides home-based and OPD-based care to people with life-limiting illnesses. Now, the team that works here is typically a doctor, a nurse, and a counselor, because we know people with life-limiting illnesses like cancer, liver problems, kidney, who are facing very chronic illnesses, also have a lot of stressors in their life, and therefore they need psychosocial support. And this program works again here very closely with patients and the caregivers and the families on providing mental health support. And so I want to end by saying that at every single point in our work, so whether we're working with children on health and nutrition, with women on reproductive health and nutrition, or with adolescents on physical, reproductive and health, the issue of gender, gender-based violence, and mental health is interwoven into all our interventions, because we do know that this has an outcome on the health of the women, the children, the families, and eventually the communities. Thank you so much. Can I leave it here?
Thank you, Vanessa, for the overview of SNEHA and for really taking us through how mental health, gender, gender-based violence cuts across each and everything that SNEHA does. I would now like to invite David Ostrin to tell us about the research collaboration of Violence and Mental Health South Asia, that's VAMSA. To introduce David, he's a professor of global health and Wellcome Senior Research Fellow in Clinical Science. He's based at the University College London, but he's been working with SNEHA for 18 years on a series of collaborative projects. Since 2009, he has been partnering with the Program on Prevention of Violence in SNEHA, and he was the principal investigator of the VAMSA Global Health Research Group.
Thank you very much, Rukmini. It's great to see so many of you here, and thank you to all of our friends and colleagues who've come from a socio-ecologic model with Mumbai, the state, the region, the country, and other countries. It's really fantastic to see you here. So my job is to stand in for somebody else, who is Dr. Delandev Kumar, who is the current principal investigator of the VAMSA group. Actually, I did lead the group for some years from its beginning, and as Rukmini said earlier, it's been going for 4 long, difficult, but very productive years. So what is it? Lots of the members are here with us today, particularly from Goa and Sri Lanka. Welcome. VAMSA, Violence Against Mental Health in South Asia, is the short name of something with an incredibly long name, which is this NIHR Global Health Research Group. And what we wanted to do was, when we started 4 years ago, was to develop a package of care for the mental health of survivors of violence, specifically in South Asia, but our hope is that this is globally relevant. So our aim was to develop an intervention to improve the mental health of actually 3 different forms of violence: violence against women, and particularly domestic violence and intimate partner violence, modern slavery, and civil conflict. And our 3 partner focus countries are India, Sri Lanka, and Afghanistan. So just to give you a little bit of background, everyone here will be familiar with the top statistics, which are that about, or just over, 1/3 of women in their reproductive years have experienced some kind of physical or sexual violence. Statistics. And as others will say, these are only 2 of the forms of violence that people can experience. So this is only part of the big number of women who have experienced violence. 19% of women will have experienced it in the last year. These are the newest global figures. And so in our 3 focus countries, we have Afghanistan, India, and Sri Lanka, and there are analogous findings. Unsurprisingly and tragically, the numbers are higher in Afghanistan. So modern slavery, and we have been working, and I know that people who know much more about modern slavery than me have been working on this for a little bit of time. And it's an issue that perhaps we're not so familiar with the statistics about. So about 40 million people in the world. And essentially, the way it's thought of now, it's classified into two big blocks. One of them is forced labor, 25 million people, and one of them is forced marriage, 15 million people. And within forced labor, we have state-imposed labor, we have forced labor exploitation, we have forced sexual exploitation of adults and also of children. And the South Asian countries are net senders of modern slaves. So we send out more people into modern slavery than we receive. At the moment, we think that in every 1,000 people in Afghanistan, 22 are victims of modern slavery. Actually, these percentages are all awful, but if you look at the numbers, India's a very big subcontinent, and that's 8 million people, which is a giant number. So what did we want to do? And I'm going to say something funny now. I think we managed to do. We wanted to do 3 big things in our global group. One of them was scope out what the background was for the package. One of them was to develop the package, and one of them was to try it out. And so within the scoping, what we did was we tried to work out, well, what kind of things would a package of care for the mental health of survivors of violence have in it? What candidate things could go in it? And a lot of that was very intensive reading of papers, but it was also talking to lots of experts. Then we actually collected new information in a number of places from people about what the needs were, what the mental health burden was. And then we worked with survivors of violence themselves and providers, be it social workers, psychologists, psychiatrists, police, to understand what might be useful, what people wanted and needed, and what would be feasible. Then we made it. We made the package. I just said that, but it took about 3 years. We made it in collaboration with survivors and providers from other organizations, including many NGOs. We tried to work out what should be in this package and put it in the package. And then we tried to develop theories, because we're very into theory. It's my fault, maybe. How do you think this would work? If people need something, how do you think we should give it to them? And what will they receive, and how will this improve their life? And then finally, we tried it out, and we'll hear a little bit about that later. So this is a total for everywhere. So we had quite a lot of workshops and consultations about this theory of change, how it should work, about how to develop the intervention itself. We had specific workshops with people that work in shelter homes, with groups that work on modern slavery, with people that specifically work on mental health. And then we also had a thing where we said, well, so here's the package. What do you think of it, and how can we improve it? And we hope we've taken on board everybody's suggestions. And we also interviewed people one-to-one. So across our group, that's nearly 150 survivors of violence who were interviewed, over 100 service providers, and also in Sri Lanka, young women, and in Afghanistan, 60 men were interviewed. And then we looked at also data from our counselling centres that Dr. Nyrene's already taught us about. In all of this, we have all had a pretty rough few years. And the 3 aspects of roughness that we struggled with were Mr. COVID on the left. 1 year ago, last week, there was a change of government in Afghanistan. The situation there has never been easy. particularly for our colleagues at Hawker, humanitarian assistance for the women and children of Afghanistan, and things became extraordinarily difficult. And on the right, you see that only the latest of many struggles that our friends, some of whom I can see from Sri Lanka, have faced was, well, essentially the fall of the government only a few weeks ago. But that was, I want to say the culmination, because I hope it's the end of a series of things, cross fingers. But, you know, things have not been easy in Sri Lanka for a number of years. Now, everyone who's doing projects, particularly global collaborations, has faced these problems. But I guess the Afghanistan and the Sri Lanka situation are maybe exceptional. So we did, apart from reviewing other people's literature, we did our own literature reviews, and specific members of the groups, and a number of them have been published. I won't go into them, don't worry. But one of them is about what works to improve the mental health of women survivors of intimate partner violence. One is about community prevention of violence against women. One is about the situation in conflict settings, and one is about the situation of mental health, or what to do about what works for mental health in human trafficking. So this slide is not designed for you to be able to read it, although on this amazing screen maybe you can. But this is an illustration of 3 years of work working on theories of change and pathways of care. So this is an idea that we'll talk a bit more about in the symposium tomorrow and the next day, where it's divided into 2 main sections, which we've called outside and inside. Outside is the situation that, as a woman, I find myself in, the violence, the struggle for income and family stability, etc. Inside is what's in my mind, how I think, my feelings, my thoughts, my cognition, my emotions. And this little sequence of things that we would hope that a survivor of violence goes through. And then towards the right, you see our menu of things that we felt that a counsellor should be able to provide, and you'll hear more about all of these from other people today. So today we're going to have presentations of varying stages of the packages of care that have been developed. For understandable reasons, we don't have anyone from Afghanistan with us today, but we hope that people will be able to join for the symposium, probably by WhatsApp. But packages have been developed by Sangat, our colleagues in Goa, by SNEHA, our colleagues here, by our colleagues from VAMSA Sri Lanka, who will talk to you today, and by our colleagues in Afghanistan. And this is a big group. If your name isn't in this group, I'm really sorry, but it's been an extraordinarily enjoyable experience working with so many different people with different backgrounds from all over the world. And I hope very much that you enjoy the actual presentations of the packages later today. And thanks very much for having me.
Thank you, David. We will now would like to invite Dr. Abhijit Nadkarni and his team of Shehzad Hussain and Lalan Madgaikar to join us on the stage. If Shehzad and Lalan, please, Dr. Nadkarni, I'll just do a small introduction. We have other people as well from Sangat. Please welcome on the stage. We may need a chair. So I'll introduce Dr. Nadkarni, and I'll request him to introduce the team, please. Abhijit is a tenure-track associate professor of global mental health at the London School of Hygiene and Tropical Medicine. He is an addiction psychiatrist and global mental health researcher conducting research aimed at developing and evaluating interventions for increasing access to mental health care in low-resource settings. His host institution in India is Sangat, which is a mental health research NGO where he's the director of the Addictions Research Group. And he's joined by the team that has been instrumental in putting together the package of care. So I'll invite Dr. Nadkarni and also request him to introduce the team and the package.
Sure, thanks. Okay, I wasn't told that I was supposed to introduce my friends from Sangat, but here I am. I'll just go by the sequence as they are sitting here. So these are broadly all the folks who have done all the hard work, but I get to stand here and stand in the spotlight and get all the accolades. But Shahzad, who is coordinating our work in Mehsana in Gujarat, Lalan, who is doing a lot of the clinical work, providing the services and supervising counselors, etc. Urvita, early career researcher who has been kind of doing the coordinating at the research level. Anushka, who is a key part of the intervention that has been developed, and I'll be talking a little bit about that. And Devika, who has been the life force behind all of the intervention, development, and then the delivery, and then just generally keeping us on our toes to make this happen. And of course, Kedar, thanks for coming in and sitting in, otherwise I would have missed you out. But Kedar, again, who has been a key part of the clinical team, which has supervised and who kind of ensures that the intervention that's being delivered is to the highest quality. So that's our team from Goa at Sangat, who has been doing all the hard work. So I can get on with the work. So I'm going to kind of talk a little bit about the work that we have done in Goa as a part of this intervention package development. We're going to do this in two parts. I'm going to just give a higher level overview of the thinking behind the development of this intervention and the process behind it. And then I'll hand over to Lalan and Shahzad to talk about the actual work that's happening on the ground, because I think that's the most important bit of it, what happens on the ground, rather than us sitting in our offices and thinking what might be the right thing and what might be the best way of doing things, but the real work happens on the ground, as we all know. So how did it all start? Because this is not an area of work that we have done at Sangat or within our research group until this opportunity came along. So our area of work over the years has primarily been around addictions. And within that, we're working with people with alcohol use disorders, developing interventions for them and providing those interventions, testing and providing those interventions. While doing that work, where we were primarily working with men with alcohol use disorders, we realized that there was this huge burden on family members of people with drinking problems that we were not addressing. And so that got us thinking. I mean, we're just kind of looking at a part of the problem and not looking at other aspects of addictions which have a close interaction with the drinking, and they are also getting impacted by the drinking in the men. So the next step for us was to develop and test an intervention for family members of those who had drinking problems. While we were doing that work, we realized that So while we were doing that work, we realized that amongst this group of family members who were affected by addictions, there were mainly in this case spouses who were getting affected by intimate partner violence, and we were not doing anything about this. And the reason for not doing anything about that was, in our defense, was that we did not have any expertise in working with survivors of domestic violence. But at one point, that defense did not hold, and it became an ethical imperative for us to intervene, because we realized that referring people to services was not really working because these services did not exist or were not of the highest quality. And we thought, if that's the case, then we need to do something about this. And that's where this whole program came about, because we reached a stage where we realized that there's a high burden of domestic violence amongst the people that we were working with. We realized that it had a big impact on people's mental as well as physical health. We also realized that there was a flawed treatment response. So even if we were sending people to access services, what they were getting there was not, if at all, if they were getting anything, was not of the highest quality, which left us with a situation where we did not really fully understand what was happening. So there was a gap in our knowledge. We also understood that there was a big gap in the resources available. I mean, even if we wanted people to get the best services that they should get for the condition or for the violence that they were experiencing, there was a problem of resource. There were not enough people who would provide this kind of service for them. And finally, there was a huge problem of contextual availability, of contextual applicability of the kind of interventions that were available. And we know from research that has been done that if we import something or we take an intervention off the shelf and try to apply it in our context, there are huge problems with that, because for something like domestic violence or intimate partner violence, there are huge contextual, societal, cultural underpinnings which do not at many times respond to interventions which we import from high-income country settings. So we said, why don't we kind of develop an intervention which responds to these contextual realities for women who are experiencing domestic violence in the context that we work with. So we went through a fairly detailed process of developing this intervention that we are going to talk about. I'm not going to go into the details of that, but basically it was a systematic process which involved looking at the global evidence, speaking to various different people and stakeholders, including survivors of domestic violence, speaking to experts, people who deliver interventions within the space, and then through formal processes of intervention development and theory of change workshops, we developed our intervention. And so what is this intervention? It's called Pahal, which is a new beginning or a new start. These are some screenshots of the intervention manual that you see here, just to give a sense of what is the intervention about and what the content is. But broadly speaking, this intervention involves what is to be delivered to the person who is experiencing intimate partner violence and mental health impact of that, and how that is to be delivered. So what you see at the top in those three boxes are the skills that we can impart or things that we work through with women who are experiencing domestic violence. And then there are generic skills of how to do this well, which is basically being non-judgmental, empathetic, open-ended questioning, etc. So these are kind of the two broad categories of how the intervention is delivered. So while we started with kind of the actual content of the intervention, we also realized very, very quickly that only delivering this intervention to the women experiencing domestic violence within an ecosystem where there is no other support is going to be problematic, because we are just solving a part of the problem. These women were living in a context where they were not getting support in other aspects related to domestic violence, and in the absence of support for that, it didn't really make sense to just respond to one part of the problem. And hence, our intervention, Pahal, became a part of a larger kind of stepped care intervention approach, which involved case management, accompanying the women to services that might help them add on to the benefits that they might get from Pahal, and referral to other service providers. So we created a larger program. Within Pahal was just one specific intervention responding to the mental health needs and of women experiencing violence. But that was just an intervention that we developed through a systematic process. Now, the proof of the proverbial pudding lies in, we know, the eating, and in this case, in research constructs, it's basically about first testing whether what we have developed is feasible to deliver within the context that we are working with, and if it is acceptable to the people for whom we have made this intervention and the people who are going to deliver this intervention, in the absence of which it's not really a very useful intervention. And so we tested the acceptability and feasibility of this intervention that, or rather testing even as we speak, the acceptability and feasibility of this intervention at two sites, one in Goa and the other site in Mehsana in Gujarat. So that is broadly kind of the context within which this intervention is developed. I will, as I said right at the beginning, now hand over to my colleagues from Mehsana and Gujarat to tell us a little bit about their experiences of actually implementing this intervention at two different sites, because that is, as I said, the true proof of the pudding, or in this case, the true proof of Pahel, as the first step towards determining whether this intervention is useful in reducing the mental health effects of domestic violence or not. So, over to you, Lalan. Okay.
गुड मॉर्निंग एवरीवन। सो मैं हिंदी में बात करूँगी क्योंकि मैं कंफर्टेबल हूँ हिंदी में, तो एक्सक्यूज़ मी फॉर दैट। सो पहल जो प्रोग्राम इंटरवेंशन जो गोवा में हुआ वो बेसिकली वुमेंस के लिए था। ओके तो हमें पहले मतलब मैं प्रोसेस बताने जा रही हूँ हमने क्या क्या किया। तो पहले जब हम माइंड में हमारे बहुत कुछ था कैसे वुमेन्स हमें मिल जाएंगे, तो पहले हमने क्या किया कि जहाँ पे महिलाएं हमें मिलेंगे वहाँ हम लोगों ने स्टार्ट किया मतलब मीटिंग्स करना, मतलब फॉर एग्जांपल सेल्फ हेल्प ग्रुप्स, अपना पंचायत, NGOs, अपनी ये जो बाई होती हैं उनके साथ हमने मीटिंग करवाना शुरू कर दिया, उनके साथ बात करना शुरू किया। तो शुरू में क्या हुआ कि हमें उतना ज़्यादा रिस्पांस नहीं मिला। मतलब जब हम जाते थे मीटिंग करने में तब क्या होता था कि ग्रुप होता था 20 लोगों का, तो जब हम बात करते थे हम लोग सब कुछ उनको बता देते थे कि ये है कि हम लोग क्या करने जा रहे हैं, हमारे प्रोग्राम क्या हैं, उसके बेनिफिट आपको क्या मिलेंगे, कॉन्फिडेंशियलिटी फ्री है, ये सब कुछ हम उनके बता देते थे। लेकिन क्या होता था 20 में से एक भी रेफरल हमें नहीं मिलता था शुरू में। तो हमने क्या किया, अभी सोचना पड़ा कि क्या हो रहा है। तो जब हम बात करते थे उन वीमेन के साथ तो वो बोलते थे नहीं मेरी एक मेड है उसको शायद ज़रूरत होगी, या नहीं तो मेरे यहाँ पे एक मतलब गरीब लोग रहते हैं उनके यहाँ मैं जाके पूछती हूँ, उधर से आपको रेफरल मिल जाएगा। तो क्या होता था हमें पता चला कि ये लोग बोल रहे हैं कि हम उस गांव के नहीं हैं, ये टेंशन के गांव के हम नहीं हैं। इस तरह से मतलब हमने थोड़ी स्ट्रेटजी उसके बाद चेंज करना शुरू किया कि हम लोगों ने एग्जाम्पल शेयर करना शुरू किया, एक्सपीरियंसेस बताने शुरू किए। जैसे कि देखो हस्बैंड जब हमें टॉन्ट मारता है या कुछ भी बोलता है तो हमें कैसा लगता है, हमें वो बोलते थे कि हमें बहुत बुरा लगता है, हमें बहुत ऐसा होता है कि उनके साथ बात ही ना करूं। उसके बाद क्या होता है तो मुझे बहुत गुस्सा आता है, अभी मैं कॉन्सेंट्रेट भी नहीं कर पाती हूँ। तो ऐसा मतलब हेल्थ पे भी इफेक्ट दिखाना हमने शुरू कर दिया। तब जाके थोड़े आंगनवाड़ी वर्कर्स बाई जो थे खुद को रेफर करना शुरू करने लगे। तो इस तरीके से शुरू हुआ। कभी कभी क्या होता था ग्रुप होता था लेकिन हिचकिचाते थे, बहुत सी महिलाएं आने में हिचकिचाती थी। तो हमने किया कि एक बार मतलब हमारी मीटिंग शुरू हो गई, हम आते थे तो हम 5 मिनट स्पेंड करने लगे उधर और उनको बताने लगे कि क्या है, क्या आपको कुछ क्वेश्चन है, क्या आपको कुछ बताना है, क्या समझ में आया क्या। और झट से हम उस महिला के पास जाते थे जो हमें लगता था कि इसको कुछ बोलना है। तो वो उससे बात करने के बाद वो बोलती थी हाँ मुझे बात करनी है आपसे लेकिन यहाँ मैं नहीं कर सकती, मैं आपको फ़ोन कर दूंगी। और हम ब्रोशर और फ़ोन नंबर्स उनको शेयर करते थे। कभी कभी ये 4 अगर रेफरल मतलब आ गए हमारे पास, मतलब ये आने वाले हैं, तो 4 में से 2 फोन करते थे, 2 इंस्पिरेशन उनका खत्म हो जाता था हमें फोन करते करते। तो दूसरे दिन क्या होता था, 2 मिस हो जाते थे, रेफरल जो मिलते थे 4 में से 2 मिस हो जाते थे। तो हमने क्या किया कि एक छोटा सा पेपर उनको डिस्ट्रीब्यूट करना शुरू किया मीटिंग में, और उनका फ़ोन नंबर और नाम लिख के हमें दे दो। अगर किसी को और चाहिए, मतलब अर्जेंटली हमसे बात करनी है, हेल्प चाहिए, तो यहाँ वहाँ पे कुछ भी सिग्नल छोड़ दो, स्टार बना दो या कुछ भी बना दो, ऐसा करके हमने ये किया। ये बहुत वर्क किया बहुत जगह पे, और हमें रेफरल मिलने लगे। और रेफरल मिलने के बाद हमने स्क्रीनिंग भी शुरू किया। अभी स्क्रीनिंग करने के बाद क्या हुआ कि हमें 2 ग्रुप में मिलने लगे, इनएलिजिबल और एलिजिबल। इनएलिजिबल जो थे उनके साथ तो हम हमारा प्रोग्राम में 6 सेशंस करते थे, जो पहल वाला जो था, लेकिन इनएलिजिबल थे, उनके साथ क्या करें, तो वो भी सोचना पड़ा। जो डिस्कशन हुआ तब ये आया, उनको भी कुछ तो हेल्प चाहिए, इसीलिए तो हम वो आ गए हैं हम लोगों के पास। तो उनको हम रेफरल देते थे, या संगत में हम उनको रिफ़र करते थे किसी डिप्रेशन या टेंशन की वजह से, अगर उनका GHQ स्कोर ज़्यादा हो। तो इस तरीके से शुरू हुआ। और इसके बाद काउंसलिंग सेशन, पहले हम बेसलाइन करते थे। बेसलाइन हमारा बहुत बड़ा था, लंबा था, तो 7 to 8 टूल्स उसमें थे, और वो बेसलाइन हम करते थे। तब भी हमें डिफ़िकल्टी आई कि एक करते समय एक आधा घंटा तो ऐसे ही निकल जाता था। तो उनको लगता था, पार्टिसिपेंट्स को लगता था कि अरे ये तो आधा घंटा रोज आके क्वेश्चन पूछेंगे हमें 6 सेशन में, तो कैसा रहेगा, और सेशन बाद में, तो इतना टाइम तो हमारे पास नहीं है। तो उनको बोलना पड़ता था कि ये पहली बार और एंड में हम करेंगे, बीच में सिर्फ काउंसलर आपसे बात करेगी। तो वो थोड़ा ये हो जाता था। और उसके बाद एंड सेशन में क्या करते थे, यही जो बेसलाइन किया है वही हम एंड लाइन में भी असेसमेंट करते थे, और एक छोटा सा इंटरव्यू करते थे। असेसमेंट इसलिए करते थे ताकि इधर से, मतलब जब आया क्लाइंट हमारे पास आए थे तब कैसे थे, क्या उनका स्टेटस था, और सेशन लेने के बाद क्या मतलब इम्प्रूवमेंट हुआ कि नहीं, ये सब हमें पता चलता था। एक इंटरव्यू करते थे, उसके हिसाब से हमको मालूम पड़ता था कि क्या अच्छा था हमारे प्रोग्राम में, क्या अच्छा नहीं था, क्या वर्क हुआ, क्या वर्क नहीं हुआ। और उनके पास से सजेशन भी मिलते थे, आपको क्या चाहिए, अगर ऐसा क्या होता तो आप और कंफर्टेबल होते। तो मैं एग्जांपल देना चाहूँगी, ऐसा एक सजेशन आया कि हमारे जो काउंसलर थे बहुत यंग थे, और ये महिलाएं थी, तो उन्होंने बोला लास्ट इंटरव्यू में कि अगर ये लड़की की जगह कोई महिला होती, शादीशुदा होती, तो हम लोग ज़्यादा कंफर्टेबल होते। तो ऐसा था। उसके बाद सेशन शुरू हो गए सब। हम तो मतलब पहल में अभिजीत ने बोल दिया कि कितना सारा स्किल्स हम थे कि असर्टिव कम्युनिकेशन, हर एक चीज़ के लिए हमारे पास कुछ ना कुछ था जो हम कर सकते थे क्लाइंट के साथ। तो उसके हिसाब से हम करते थे, लेकिन इसमें भी बहुत सारी दिक्कतें हमें आई। कभी कभी क्या होता था, अगर किसी औरत का हस्बैंड का अगर अफेयर हो, तो वो अफेयर के लिए हमारे पास तो कुछ नहीं था, हम क्या करते। सो हम सुपरविजन में, हर सुपरविजन में इस पे डिस्कस करते थे, डिस्कस करते थे और डिसाइड करते थे क्या करना है। और पीयर ग्रुप और सुपरवाइजर ग्रुप, और हर सेशन हम सुन के रेट करते थे शुरू में उनको, ताकि पता चले व्हाट स्किल एंड हाउ स्किल दोनों वो अच्छे तरह से कर सके। और अगर कोई भी ऐसा होता था सेशन में, गिविंग होप बहुत ज़रूरी होता है सेशन में, लेकिन वो नहीं आता था काउंसलर के साथ, क्योंकि काउंसलर भी नए थे हमारे, तो नहीं आता था। तो वो कैसे देने का, क्या करने का, उसका मॉक सेशन में हम करते थे, रोल प्लेस करते थे। इसके हिसाब से काउंसलिंग, मतलब उनको हम और ज़्यादा काउंसलिंग में अच्छे से करने के लिए प्रोत्साहित करते थे। ये होने के बाद क्या हुआ कि जब अफेयर के बारे में मैंने बोला, हस्बैंड के अफेयर के बारे में, या कोई ऐसा होता था कि कोई कुछ भी ये होमवर्क दिया, तो होमवर्क करके नहीं आते थे। अगर एक एक्टिविटी दी तो आज नहीं की, तो काउंसलर पे प्रेशर आ जाता था, अब क्या करूं। तब हम डिसाइड करते थे बैठ के कि क्या करना है। कभी कभी ऐसा होता जाता था, हम अफेयर अगर हस्बैंड 15 दिन में एक उसका कुछ कुछ सुनाई दे रहा है, सुनने में आता है, और ये औरत जो अभी इम्प्रूव हो रही है, लास्ट सेशन तक अच्छी थी, अभी उसका एकदम ड्रॉप हो जाती थी क्योंकि उसका कुछ और अफेयर या कुछ समझ में आता था, तो हेल्पलेस हो जाते थे हमारे, ये बहुत दिक्कत होती थी। और उनको भी ये भी समझाना पड़ता था हमारे काउंसलरों को कि सब कुछ हमारे हाथ में नहीं है, तो हम जो भी करेंगे मतलब जो जितना हो सके उतना ही कर सकते हैं, ज़्यादा हम कुछ मतलब नहीं कर सकते। और अगर वो हम लोग उनका अफेयर स्टॉप नहीं कर सकते या और कुछ नहीं कर सकते, तो हम लोग उस औरत को तो स्ट्रॉन्ग बना सकते हैं। इस तरीके से हम करते थे। और
Good morning, everyone. First of all, thank you organizing committee to giving me chance to present my learning experience from rural site Mehsana, and especially thanks to Abhijit and Devika, Urvita and my team to giving me chance to present my learnings. So basically moving forward to my work experience, before that I want to share some information in regards Mehsana and their contextual aspect. So जब हमने मेहसाना में अपने काम की शुरुआत करने का सोचा, so basically उस वक्त हमने हमारा जो काम था वो मेहसाना में CMHLP सेंटर फॉर मेंटल हेल्थ लॉ एंड पॉलिसी के एक ऑर्गेनाइजेशन के एक प्रोग्राम आत्मीयता प्रोग्राम के अंतर्गत हमने हमारे रिसर्च प्रोजेक्ट को शुरू करने का फैसला किया। सो बेसिकली इन द स्टार्टिंग फेज हमने सबसे पहले अगर हम देखें तो मेहसाना के अंदर, मेहसाना जो एक डिस्ट्रिक्ट है नॉर्थ गुजरात का, जिसमें अराउंड 7 to 8 तालुकाज हैं और उसके 120 से 130 विलेजेस अभी है। सो अगर हम बात करते हैं तालुकाज की, तो तालुकाज काफी सेमी अर्बन टाइप्स के हैं, लेकिन अगर हम बात करें विलेज लेवल्स की तो वो बहुत ही रूरल कम्युनिटीज वहां पे है। सो हमने वहां पे शुरुआत की आत्मीयता के साथ। अब यहाँ पे बात आती है व्हाट इज आत्मीयता। सो आत्मीयता एक वॉलेंटियरली प्रोग्राम है, जैसा कि अभी मैंने बताया, जो कि CMHLP के द्वारा रन किया जा रहा है, जिसके अंतर्गत वो ले काउंसलर को वहां पे चैंपियन के नाम से पुकारा जाता है, जो कि काउंसलिंग प्रोवाइड करते हैं सामान्य मानसिक तान तनाव या सामान्य मानसिक तनाव के केसेस में। ये ले काउंसलर कम्युनिटीज में से ही होते हैं, लाइक ये आशा वर्कर्स हो सकते हैं, लाइक ये हाउस वर्कर्स हो सकते हैं, ये आंगनवाड़ी कार्यकर्ता हो सकते हैं, और कुछ ANMs भी हो सकती है। सो हमने यहाँ पे कार्यक्रम की शुरुआत करते समय मेरा वर्किंग एक्सपीरियंस मैं 3 फेज में बांटता हूं आप लोगों के लिए। First one is exploration phase, second learning, and third one is research implementation phase. Exploration phase is all about to know about the Mehsana context and know about the Atmita program. And learning and teaching phase is like whatever trainings we conducted during the implementation of our research project. And research implementation phase is the real phase in which we implemented our PAHL intervention that Abhijit mentioned earlier. So if we are looking to first phase, exploration phase, इसमें हमें ये जानना था कि मेहसाना में वास्तव में नीड क्या है, मेहसाना के कॉन्टेक्स्ट में क्या क्या चीजें हम कर सकते हैं। सो बेसिकली इस फेज के अंदर हमने जो 2 चीजें की, फर्स्ट वन इज नेटवर्किंग, सेकेंड वन इज साइट स्ट्रेस प्लेसमेंट। तो नेटवर्किंग के अंदर हमने अराउंड 110 से 120 लोगों से हम मिले उन 7 तालुकाज में से, और उनमें से हमने बातचीत की और ये पता लगाने की कोशिश की कि जो डीवी सर्वाइवर्स है या फिर वहां की जो कम्युनिटीज है वो डीवी के बारे में क्या पर्सपेक्टिव रखती है, डीवी के बारे में क्या जानती है, और किस प्रकार का डीवी वहां पे देखने को मिल रहा है। वहां की अगर डीवी सर्वाइवर्स है तो उनको किस प्रकार की हेल्प की जरूरत है। सो उसको हमने आइडेंटिफाई करने की कोशिश की। इस फेज, मेरे लिए ये फेज काफी लंबी रही। अराउंड मैं मेहसाना शिफ्ट होने के बाद तकरीबन 3 से 4 महीना मुझे बस इस चीज की पता लगाने और अपने सुपरवाइजर से डिस्कस करने में लगा कि हम क्या क्या चीजें हमारे रिसर्च वाले फेज में मेहसाना के कॉन्टेक्स्ट में मॉडिफाइड कर सकते हैं। सो जब हमें काफी विजिट से डेटा प्राप्त हुआ, देन वी फाइनली हमने जो सेकंड पॉइंट मैंने मेंशन किया है, साइट को एस्टेब्लिशमेंट किया। वहां पे हमने आत्मीयता प्रोग्राम को पूरी तरीके से समझकर, आत्मीयता प्रोग्राम को जानकर साइट को बनाया और फाइनली हमने वहां की आत्मीयता टीम मेंबर्स में से कुछ मेंबर्स को रिक्रूटमेंट शुरू किया हमारे नेक्स्ट फेज के लिए। सो नेक्स्ट फेज ये गोवा से थोड़ी सी अलग रही हमारे लिए। सो इसके अंदर हमने बेसिकली अगर हम बात करें गोवा के अंदर, तो गोवा में सीधा गोवा एक्सपर्ट्स ने हमारे ले काउंसलर को ट्रेन किया था। लेकिन मैंने मैं और एक हमारे आत्मीयता टीम से एक्सपर्ट साथ गोवा गए और हम लोगों ने पहल इंटरवेंशन की ट्रेनिंग हमारे एक्सपर्ट से ली। वहां से ट्रेनिंग लेने के बाद जब हम वापस मेहसाना आए, तो मेहसाना आके हमने सीएफ्स के लिए, सीएफ्स लाइक अभी एक चीज और मैं यहाँ पे थोड़ा सा मेंशन करूंगा कि आत्मीयता जो है 3 टियर सिस्टम पे काम करता है। फर्स्ट वन इज प्रोजेक्ट मैनेजर, second one is community facilitator and third one is champions. So जो community facilitator होते हैं उनको सुपरवाइज करने का काम प्रोजेक्ट मैनेजर करता है और चैंपियंस को सुपरवाइज करने का काम कम्युनिटी फैसिलिटेटर करते हैं। तो हमने हमारी पहल इंटरवेंशन को इम्प्लीमेंट करने के लिए कुछ सीएफ्स को सिलेक्ट किया। उन सीएफ्स को सिलेक्ट करने के बाद उनके लिए एक ट्रेनिंग अरेंज की। उस ट्रेनिंग में हमने जो भी पहल इंटरवेंशन के दौरान हमने सीखा था, उस ट्रेनिंग में हमने उनको डिलीवर किया और उसके साथ ही साथ उनके लिए कॉम्पिटेंसी असेसमेंट एग्जाम रखा, जिसमें हम ये असेस कर सकें कि हमने जो डिलीवर किया है हमारी ट्रेनिंग से, क्या वो स्किल्स, उस स्किल्स का असेसमेंट हम कर सकें, वो स्किल्स उनमें एग्जैक्ट तौर पे हम डिलीवर कर पाए या नहीं कर पाए। देन ये एक एक्स्ट्रा फेज था जो गोवा से अलग था, सीएफ्स ट्रेनिंग। देन सीएफ्स ने गुजराती लैंग्वेज में हमारे मैनुअल्स, हमारे पीपीटी सबको गुजराती में ट्रांसलेट करवाया। देन सीएफ्स ने चैंपियंस के लिए ट्रेनिंग रखा कि जब हमने स्टार्टिंग फेज में विजिट्स की और विजिट से जो एरियाज हमने सेलेक्ट किए, उस लेवल पे हमने चैंपियंस को सेलेक्ट किया। अराउंड 20 चैंपियंस हमने शॉर्ट लिस्ट किए। उन 20 चैंपियंस में से हमने ट्रेनिंग किया उन 20 चैंपियंस को, और ट्रेनिंग और कॉम्पिटेंसी असेसमेंट के बाद हमारे पास 8 चैंपियन बहुत ही सक्सेसफुल तरीके से उस ट्रेनिंग की कॉम्पिटेंसी असेसमेंट को क्लियर कर पाए। तो इन 8 चैंपियंस के साथ करेंटली हम अभी भी काम कर रहे हैं हमारे पहल इंटरवेंशन को डिलीवर करने के लिए। सो यहाँ बात आती है कि हमने एक ऑनगोइंग प्रोग्राम, जैसे मैंने अभी बताया आत्मीयता प्रोग्राम, एक ऑनगोइंग प्रोग्राम में किस तरह हमारे रिसर्च को इम्प्लीमेंट किया विदाउट, मतलब उनकी प्रोग्राम का जो इंफॉर्मेशन फ्लो है या उनकी सिस्टम को चेंज किए बगैर। जैसा अभी मैंने मेंशन किया था कि जो आत्मीयता प्रोग्राम है उसमें अगर आप स्लाइड्स में देख रहे हैं तो आत्मीयता प्रोजेक्ट मैनेजर, CFs एंड चैंपियंस। CFs मीन्स कम्युनिटी फैसिलिटेटर। सो हमने हमारे इस इम्प्लीमेंटेशन के लिए 2 टीम्स बनाई गोवा से। फर्स्ट वन फॉर रिसर्च, सेकेंड वन फॉर क्लिनिकल वर्क। फॉर रिसर्च वर्क हमने 4 CFs को सिलेक्ट किया था, उनमें से 2 CFs को पूरी तरह से रिसर्च प्रोसेस के लिए हमने उनको ट्रेन किया। उन 2 CFs के साथ हम हर वीक मिलते थे और वीक में 1 घंटा या से 2 घंटे के बीच हम उनका रिसर्च सुपरविजन करते थे। इस रिसर्च सुपरविजन में हमने आत्मीयता प्रोजेक्ट मैनेजर को भी इंक्लूड किया ताकि हम एक इंफॉर्मेशन फ्लो उनके सिस्टम के साथ एस्टेब्लिश कर सके। और सेकंड टीम जो गोवा से थी क्लिनिकल सुपरविजन के लिए, तो जो अदर 2 CFs थे उनको हमने पूरी तरीके से हमारी ट्रेनिंग में ट्रेन किया था हमारे पहले इंटरवेंशन के लिए। तो जब भी क्लाइंट्स को सेशन लेने के बाद चैंपियंस जाकर अपने CFs को बताता, सेशन अपडेट्स देता, तो वो सेशन अपडेट्स देने के बाद जो कम्युनिटी फैसिलिटेटर होता था वो अपने चैंपियंस को अपना फीडबैक देता। सो बेसिकली दो वीक में एक बार जो कम्युनिटी फैसिलिटेटर है वो हमारे साथ ऑफिस आके 2 वीक में एक बार क्लिनिकल सुपरविजन लिया करते थे क्लिनिकल एक्सपर्ट्स के साथ। तो इस तरीके से मतलब एक ऑनगोइंग प्रोग्राम को विदाउट उसको चेंज किए हुए हमने हमारे रिसर्च को इम्प्लीमेंट किया। जब हम कहीं बाहर की साइट में जाके कभी भी कोई प्रोग्राम इंप्लीमेंट करते हैं तो वहां पे हमें काफी चैलेंजेस देखने को मिलते हैं। सो बेसिकली मेरे लिए सबसे बड़ा चैलेंज जब प्रोग्राम को इंप्लीमेंट करना था उस वक्त ये जानना था कि हम कैसे कर पाएंगे, एंड सेकेंडली हम क्वालिटी को कैसे मेजर कर पाएंगे, क्वालिटी को किस तरीके से मॉनिटर कर पाएंगे। सो बिगेस्ट चैलेंज ये आया क्योंकि गोवा कॉन्टेक्स्ट में हमारे लिए हर सेशन की रिकॉर्डिंग्स थी, लेकिन मेहसाना के लिए हम किसी प्रकार की रिकॉर्डिंग्स नहीं कर रहे थे। सेकेंडली अगर देखें तो जो चैंपियंस था उनके लिए पेपर और पेन यूज करना एक्सेप्टेबल नहीं था ड्यूरिंग द सेशन। तो ये भी हमारे लिए एक एग्जैक्ट नोट्स नहीं आ पाता था सेशन से कि हम किस तरीके से क्वालिटी को मेजर कर पाएंगे। तो इस तरीके के दो चैलेंज जो हम कह सकते हैं कि बड़े लेवल पे हमने फेस किए। और इसके साथ साथ जब भी आप किसी प्रोग्राम के साथ काम कर रहे हैं, किसी ऑर्गेनाइजेशन के साथ काम कर रहे हैं या किसी सिस्टम में काम कर रहे हैं, तो आपको चीजें हर टाइम मॉडिफाई करने की जरूरत होती है, तो आपको थोड़ा सा फ्लेक्सिबल रहना होता है। तो बेसिक लर्निंग मेरी जो थी, जो बड़े बड़े वर्ड में अगर बोले तो फ्लेक्सिबिलिटी, मतलब आपको अपनी चीजों को फ्लेक्सिबल रखना पड़ेगा किसी भी चीज को इंप्लीमेंट करने के लिए। दूसरा ये कि जब भी आप कॉन्टेक्स्ट को देखते हैं, जैसे मेहसाना कॉन्टेक्स्ट गोवा से बिल्कुल डिफरेंट था, तो कॉन्टेक्स्ट के अकॉर्डिंग आपको आइडेंटिफिकेशन करके अपनी साइट का, उसके बाद ही हम आगे बढ़ सकते हैं। सो बेसिकली जब भी हम किसी साइट पे काम करने का सोच रहे हैं या किसी चीज के बारे में देख रहे हैं, तो हमें उस चीज का कॉन्टेक्स्ट पहले से पता हो तो हम बहुत ही बेटर तरीके से उसको इंप्लीमेंट कर सकते हैं। सो थैंक यू सो मच।
Thank you very much to everybody from the Sangat team. Thanks a lot. We will now move to the SNEHA team, and I'd like to invite Dr. Naireen Daruwala and the team from SNEHA that has been instrumental in working on the package, Krishna, Prarthana, Aishwarya, and I will also join the team. To introduce Naireen, Naireen heads the components of research, partnership, and scaling of SNEHA's program on prevention of violence against women and children. She has over 2 decades of experience in working towards incubating and establishing programs on prevention of gender-based violence, particularly through mental health counseling and crisis intervention for survivors, through community mobilization and public engagement, through art and research. Her expertise is in building models on prevention of gender-based violence in middle-income contexts, and she has developed SNEHA's convergence model for it. Naireen's research. One more line. Naireen's research, program designs, and scholarship have contributed to the gender-based violence discourse in South Asia.
Thank you, Rukmini. Welcome all, and thank you very much. I'm very happy to present SNEHA's mental health research and the development of package of care. But before I present, I need to introduce my team members to you. We were a small team. And let me introduce Prarthana Loya, who was a counselor earlier in SNEHA and then moved into the research team. Aishwarya Natekar, she has been a clinical psychologist for SNEHA for the last many years, and we moved her to the research project. Krishna Kanchal, social worker, she is instrumental in really getting the whole package developed and also has helped a lot in the content. Rukmini Bhatta, who has been with us, helping us with the content and helping us reach out to several NGOs. So thank you all, and of course, not to forget to mention David. David has been working with all of us to develop the package of care. Yes. So, SNEHA has integrated gender-based violence and mental health interventions for a very long time. And our interventions have been integrated into primary, secondary and tertiary intervention. Now when we say we have integrated mental health and gender-based violence, we are not experts. We have been only exploring ways and ways to see how we can really provide holistic help to women. In our experience, what we really saw is that in addition to women who are suffering from diagnosed mental health diseases, there are many millions of women who suffer from mental health conditions on account of very difficult situations. And the reason what we found when we analyzed was mostly women spoke about the stresses of gender role differences, responsibilities, and the main reason, the gender nature and response to conflict, which we see in intimate partner and domestic violence. This is a graph of our counseling centers. The numbers that you see here, in the last year, there were 7,830 survivors registered with our counseling centers, out of which 7,404 survivors were assessed for any kind of mental health system. Now what do you see here? What you see is there is a major jump between moderate and diagnosed as moderate and mild conditions of mental health, both for anxiety and both for depression. What does it really indicate? And secondly, what do we do? They do not need any kind of clinical intervention. Women are very scared of clinical intervention because once they are proved to be clinically, mentally not sound or any other thing, there are dangers of them not being taken back in the family, and there are many other multiple issues that women have to go through. So what do we do with these women? That is why our focus in the last few years has been to really see if we can help counselors who deliver counseling interventions to integrate mental health along with GBV intervention. The package of care that I'm going to show the content now, we have created in order to help other organizations, in order to help our counselors understand how to integrate mental health along with GBV intervention. And the reason for that is GBV interventions are solution focused. And it is quite natural when the woman comes in a very distressed situation, of course, and what she really wants always is, can you help me improve my situation? She doesn't talk about mental health. She doesn't talk about, oh, I'm feeling low, I'm feeling this. All she talks is, help me improve my situation. What we realized is gender-based violence interventions are not enough because the counselors can work on the situation of the woman. But what about her emotional regulation? What about her own understanding about her problem? How do we help her in these things? Integrated approach, what we have seen, has led to holistic care and support. Also, it increases when mental health interventions are integrated, it helps in increasing resilience, coping of the woman, understanding and emotional regulation. So this is an attempt to demystify mental health intervention in order to have mainstream mental health intervention with GBV intervention. Women have often in our counseling center, we refer women to the clinical psychologists, then we refer women to the lawyers, and women have often spoken about that please let us talk to one person who can help us out rather than talking to 10 people. Why did we do a package on modern slavery and domestic violence. First of all, we did a lot of research on how information is consumed. And what we really understood is information these days is consumed the best online in small chunks, and if it is available at any point of time, when people are free, they can use the information, they can avail it and read it at their own time. The package of care was developed over a series of consultations. Many of the NGOs are present here today, shelter home staff and organizations working on modern slavery, and the organizations, the representatives working on modern slavery have given us very valuable input in order to see how we can integrate mental health for modern slavery and domestic violence survivors. We had interviews. David has already mentioned about the interviews, but one last thing, the feasibility testing. Once we developed the package, we have tested the package with 8 organizations across the country, and we have made some changes in the package. So what are our findings? And many people have asked me, but why have you done modern slavery when you are not experts in modern slavery? True, we are not experts in modern slavery, but when our team was doing realist reviews, what really came about was that mental health interventions are not very different when you talk about modern slavery or you talk about domestic violence or intimate partner violence. What we saw, that trauma is common between these survivors. Emotions like fear, worry, guilt are common amongst both the survivors. Both survivors experience betrayal by a loved one, coercion and loss of control, and all survivors have spoken about intimate partner and domestic violence. The differences that we found through our research and through consultations were trauma is much more pronounced in survivors of modern slavery. Risk of re-traumatization is much higher because she is going through several institutions. The rescue process is very, very stressful, and the justice systems are quite distressing for the survivor of modern slavery. Additionally, there are issues of citizenship and immigration, which we see a lot with these survivors. What is the package of care? As I said, we have attempted to make this package online, and the package of care is for the use of counselors, social workers, mental health professionals who are offering gender-based violence intervention. It is a guide to understand survivors' needs, survivors' issues, survivors' feelings and mental health, and decide a pathway to support her. What does the package recommend? So we have made the package flexible and fluid for people to access it. It doesn't have to be in order. You can go to any section of the package if you want to know about a particular section. It gives a guideline and an idea on how GBV and mental health interventions can be integrated. It also provides examples of scripts. And this is our experience, that when counselors are doing GBV interventions, they are top-class interventions on GBV. But when it comes to mental health, counselors find it difficult to talk about different aspects of mental health. So we have made scripts in the package which can be used as a guideline for them to talk about mental health of the survivor. Section talks about how to get ready, what to think about, what to ask, and what to do. And we are very aware of the WHO lines which we have tried to use in all our counseling sections. There are 4 components of the package. The first package is get ready. So what should a counselor or social worker know before she helps the survivor of violence? So this section is about no information, mainly information on different kinds of laws, psychoeducation, how to support the survivor, and what information the counselor needs to have. Counseling principles, ethics of intervention, and support and resources. What resources does the counselor need to generate in order to help the survivor? This is consultation 1, and in consultation 1, if you see, there are 2 components again. One, like David said in the morning, one is the reasoning. How do you really help the woman to reason, to think, to feel what she is undergoing? How do you validate her feelings, and how do you normalize her feelings and say that this is not only happening to you, and this is whatever is happening to you is wrong? How do you provide mental health first aid and suicide prevention? I think suicide is one area where people, counselors, social workers get very jittery because of course there is a huge risk involved when you talk about suicide prevention. Distress reduction and grounding. After COVID, people have been using a lot of grounding, and I think the purpose of putting grounding exercises in the packages, all we have done is put simplified grounding exercises for the counselor to help immediately reduce the stress in a survivor. The other section is more resources. How do you psychoeducate the woman? Safety assessment. How do you provide a range of crisis interventions as per her need and go to problem solving? Consultation 2, and this is where we have integrated mental health interventions more broadly into the package. The consultation 2 is about review, exploring her feelings, supporting her mental health, and planning together. And over here again, I think why I'm emphasizing on these feelings is because mental health is not only about psychopathology and saying that this woman is having depression, that woman is having trauma, but mental health is also about making the woman understand her emotions, her feelings, and helping her to navigate through these feelings if you really want her to make decisions and build resilience. Also, in the last few years, we have been doing mental health screening for survivors of violence. It is advisable to do screening. It is not to really typecast a woman into any clinical prototype, but it is for the counselor to get a guideline on how she can provide the GBV and mental health interventions. We have provided in the package 2 types of screening. One is screening which we do at SNEHA, which is by using validated tools, and the other screening which we have added in the package is screening questions that the counselor can ask in order to understand if there is any underlying mental health condition, or if the survivor requires to take help from specialized services. So history taking, suicide risk assessment, depression, anxiety, and trauma, the questions are around these. The tools are around these on depression, anxiety, and trauma. And honestly, I think although we are not experts, it has really helped us in understanding how to help the woman better. The consultation 3 is about review, whatever techniques the counselor has spoken about or decided with the survivor. How do you review when she comes to you the 3rd time? Has she settled with her feelings? Has her emotional regulation now is in control? These are the reasons why in consultation 3, along with of course GBV intervention, the counselor can look at if there has been a difference in her situation, is she able to manage her feelings, have the intervention helped her to cope better, and why some interventions have been ineffective. There are times when intervention, the counselor tries so many different approaches, but they're ineffective. And I think these are the measures by which the counselor can know what alternative plans can be made. These are additional resources in the package if the counselor or anyone wants to understand about the whole GBV and mental health integration. What are the differences in Garima for modern slavery and for domestic violence? The survivor of human trafficking will already have been assessed as supported. So the package that we have created for modern slavery is at the point where the survivor has already been rescued and the survivor has come to an institution. So we have removed safety assessment because it is presumed that once she is in the institution, she'll be safe. In the section before you meet her, we've added a lot on human trafficking, and especially there are several forms of modern slavery. We are focusing on human trafficking. And under human trafficking, we are focusing on sex work, women in institution or shelter home, and in the community where there are chances of women being trafficked. We have changed the section on support and resources to fit the needs of survivors of trafficking. The additional interventions that we need for survivors of trafficking are trafficking survivors require very sustained intervention. The trauma that they go through, it recurs and recurs again and again, and it requires a long period of time to build emotional regulation. They need support in working through a stable identity. Because of being trafficked from one to the other place, their identity really gets compromised. And when we were doing interviews with survivors of trafficking, this really came out very clearly. Need support to overcome substance use. This is again very common with trafficked survivors. Working through stigma, and the stigma is not only because of trafficking, but the stigma is also because the home from they have come, they faced a lot of stigma. Requires support through future, and this is an interesting difference that we found when we were doing interviews, that although trafficked women were undergoing a lot of domestic violence and intimate partner violence, they were not worried about it. Their worries and their fears were more about the uncertainties of the future and their children. So this is our team, they are all here, and it has been a 1.5 years of making this package. We argued a lot, we had differences, but we did it day in and day out in order to simplify the content. And I think what we all learned is when there is so much of content available, how do you critically reflect and how do you take the content that would be most relevant for the survivors and for counselors to use it. Before I say that, I also want to say that our package is going to be developed in different languages. Right now, we are only going to present English, but we are definitely going to make it in Hindi, Marathi, and Sinhala. And I sincerely want to thank, before I end, I sincerely want to thank all the NGOs who have been participating with us over the last 3 years, government staff, academic advisors, people who have been involved in SNEHA, our communication team, Shweta and Priyanka, who have been with us all the way while we were developing the package of care, our senior management, Vanessa, Dr. Shanti, Dr. Fernandez, who always has so much faith and support and gives us that freedom to do these things. And of course, I need to thank Siriti for creating this amazing thing on the online, Ben Art, Sidit Bhagat Studios, who have made the film, and Color Singh. So here I end my presentation. The package is a tribute to all these survivors of violence who want to live with dignity and pride. And the package is a tribute to all the counselors who relentlessly work to help these survivors. Thank you very much. I would like to now call upon our chief guest, Honorable Secretary, National State Commission for Women, Madam Meeta Rajiv-Lochhan. Madam, I will give a brief introduction about you, and then we would really like you to address the audience and highlight us on this issue. So, Madam Meeta Rajiv-Lochhan is an IAS officer of Maharashtra, India. She is currently the Member Secretary, National Commission for Women, Government of India. In her illustrious career, spanning over 32 years, Madam has played a pivotal role in working for women empowerment. Her current role concerns facilitation of institutional mechanisms to provide support to women in distress and to work for the cause of women empowerment. Under her guidance, the NCW has operated a 24/7 helpline for women in distress and also for families in need of rescue and emergency supplies during COVID-19. And we know about this because we know how many calls went to National Commission of Women, and I think we heard from many quarters that National Commission of Women was working 24/7 to help these survivors. She facilitated the launch of a 6-week online training program for women entrepreneurs in collaboration with IIM Bangalore, and she has published a number of articles dealing with matters of development and public policy in reputed journals, and she has authored books on farmers' suicide and role of community in management of water supply. So, Madam, we heartily welcome you and look forward to hearing you.
Thank you so much, Nyreen. Am I audible?
Yes, ma'am, you are audible.
Okay.
Yes.
Okay. So friends, it's a privilege to be associated with the launch of this package of care. I have worked in Maharashtra for the last 32 years, and during that time I have heard so much about the work that has been put in by SNEHA in the cause of women's empowerment, and even more so for women affected by gender-based violence. So I listened carefully to this entire approach that SNEHA has described, and this is what is needed. It fits the bill, and it is a testimony to their commitment to the cause, and it speaks of the high quality of the work which they have been doing. So kudos to you, SNEHA. Friends, this problem of gender-based violence, this continues to be a very serious issue, a troubling issue for all of us. Raising the self-esteem of women who have been the victims of abuse must be our core concern. The recent NFHS data, the 5th version of the National Family Health Survey, it tells us that even today, roughly 32% women in India suffer from violence of different kinds, whether it be emotional or sexual or physical violence, and most of the time the perpetrators are their spouses. When we look further at the various aspects of this kind of violence, then we see that in urban areas the incidence is about 8 percentage points lower, and it's also interesting to see when we look at the breakup of domestic violence figures across income quintiles, that in the highest 2 income quintiles, incidence is lower, about 19 to 26%, but it does exist. And in the lower 3 income quintiles, it ranges from 32 to 40%. So why after so many years, 75 years of independence, such issues should continue to exist is something which is a matter of serious concern. And even more important is that 77% of women who suffer such abuse, that is 3 out of 4, they don't really report the abuse. 14% seek help from someone, and another 9% merely share it with their friends. So if 3 out of 4 women are not reporting whatever they suffer, then that is an indicator of a deeper malaise. What could be the reason is something that we need to look at. Today, legally speaking, India has one of the most robust laws in terms of equality of women. Women are equal before law and they have the same rights as do men. Whatever aspect of women's empowerment we choose to look at, whether we look at it economically, politically, educationally, major strides have been made in the last 75 years. For most importantly, today for the first time since 1947, we have been able to achieve a positive sex ratio. So there are more women than men in India, which says that our society is gradually turning around. When we look in terms of economics, per capita incomes have been increasing, and estimates of poverty in India range anywhere from 1 to 10%. So that is a huge difference. I remember when we joined service 32 years ago, poverty figures were much, much higher. Almost half the population could be put in the poor category. This is not the case today. Not only that, women have also participated in this increase in prosperity. Data also tells us that 3 out of 4 women in India today have bank accounts that use. When we are to look at cash availability, then 51% women in India have cash that they themselves can decide how to use. And 43% own property either individually or jointly along with their spouses. So clearly, economic empowerment has been making headway. Even in terms of politics, in 2019, the Lok Sabha election, for the first time, we had more women voters than there were men voters in the recent state assembly elections in the past 6 months. For the first time, I have heard that politicians are reaching out to women voters and addressing their concerns. It is no longer assumed that the opinion of a woman must be the mirror reflection of what her husband, her father, her brother, her son believes. If that is the case, and we have worked in Panchayati Raj institutions against a mandated reservation of 33%, we have 43% women leaders in Panchayati Raj institutions. I remember when we joined as CEOs in Zilla Parishad, this was in the 1990s, when the 73rd and 74th amendments had just been introduced. At that time, women elected leaders used to follow in the wake of their husbands, and it was their husbands who were discharging those responsibilities most of the time. But in the next 15 years, there has been a sea change, and now that is certainly no longer the case. Women have agency. Even if you look at it from the point of view of education, since the year 2018 onwards, more women than men have been registering for higher education and for school education. So when we look at all these factors, economics, political empowerment, education, there has been a vast change. India has seen a vast change. If that is the case, then how is it that women do not seem to have the confidence to report when they are suffering abuse? Or it could be another feature. Is it that many of them don't really see that this is a significant problem? This is what also Naireen referred to in her initial remarks. And actually, when we look at the data, the National Family Health Survey data and other data, we see that socially speaking, there are no serious gender wars in India. And on this issue, there are many women who don't really see this as a serious social problem. Nor is data that way is not always very convenient. It's not easy to identify a particular problem or to see it in terms of black and white shades. So it is true that today 70 to 80% women in India report that they participate in major household decisions. Men report the same. I have heard a great deal of discussion which says that, women are not free to spend their own money, and that it is a joint decision how her money would be used. The same is true of men. So 70% men report that we use our cash earnings only in consultation with our wives. But even though women continue to have a major role, when it comes to something like domestic abuse, they do not feel confident in speaking up. So here I think the main issue, the core issue that needs to be addressed is about building confidence. Friends, the government can enact laws to protect women, and we have done so. The National Commission for Women has been working for over 30 years now. We have been part of so many stakeholder consultations to review laws, to fine-tune laws from time to time, and all that infrastructure is in place. Nireen told you about the Women's Helpline that has been started last year by the LCW. This is an add-on to helplines that exist across the country in every state. If after that we are not able to build confidence in women, then surely this is a matter of low self-esteem of survivors, and initiatives of the kind that SNEHA has taken are very much needed. In the last 13-14 years, the National Commission has worked with the Tata Institute of Social Sciences on a violence-free home project. And as part of that violence-free home project, what we did was that we supported social workers who were sitting in police stations and counseling women who came to the police with their complaints. We received a very, very positive response in all these projects, and in all these cases, the state governments, many state governments have said that they will now try to institutionalize this project. At the same time, there could be two opinions, and some people have also said that it may make more sense to have a counseling mechanism, perhaps not in the police station, but somewhere else. It is in this context that the support services provided by voluntary agencies like SNEHA are so important. We are also in the process of taking over the management of over 580 family counseling centers that exist throughout the country. Over here, it will be our effort to reach out to women, to counsel them, and to see how their mental health could be improved. And here I feel that this sense of self-confidence, this sense of agency is so important. Just recently, 6 months ago, we invited this very dynamic lady, Kalpana Saroj. Kalpana Saroj is a Dalit. Currently, she is the chairperson of Kamani Tubes Limited, and her story is an inspiration in itself. She comes from a very poor family. She suffered domestic abuse herself. And when her father came to pick her up and she went back home, she faced social ostracism. After that, she was able to pick up the pieces, put her life back on the rails, and today the companies that she leads, the 6 companies that she leads, have a combined turnover of over 2,000 crores. And in the electrifying speech that she gave all of us, she said that, see, it's the sense of, do I control my own life? Am I able to take the initiative and make the decision about what is the direction in which I would like my life to go? It was that sense which was key to me. It was much more important than any money, than any education or any other help that anyone could offer me. So it is that we need to remember. I have worked in Maharashtra for over 32 years, and I have seen so many women who are in the front ranks of so many professions across the board, be it politics, be it management, be it business. So friends, we have a lot that is going for us. India is at the cusp of a major change. In order to deal with this problem in our social fabric, it is very important that all of us, all stakeholders, come together and work with stakeholders like SNEHA to see that the benefit of this package of care that they have developed, that it is extended to as many women as possible, so that they are able to pick up the pieces of their life. And even more important, the only other thing that I would like to add is that it is very important to include men in the dialogue. One thing that I have seen consistently is that we tend to address ourselves to women, but we need to address ourselves to men too. We have seen that men fight for the cause of women too. It is very wrong, I feel, to see them only in the role of abusers. They are very important stakeholders, and in fact, when we look at counseling, some of the best results are achieved through family counseling. In the violence-free home project that I just shared with you, 80% of the ladies who came to us, they were looking for reconciliation. That is also the kind of feedback that we have received from the family courts, that 80 to 85% of those cases are looking for some kind of reconciliation. So, if it is possible to involve men in the dialogue, to help them rebuild a relationship in which both parties respect each other, I think that is what is the game changer. And in the last 1 year, we have supported state commissions for women and other organizations throughout the country in the program that we call Men for Women. And we invite men all over the place. Please speak to us. Please tell everyone about the great work that you do. This is a joint endeavor. We all need to work together as stakeholders, as common stakeholders across the social spectrum in order to deal with this problem. So once again, let me appreciate this wonderful package of care that SNEHA has put together, and all other stakeholders that are present in this organization. We are here to support you in your efforts. More power to women. Thank you.
Thank you very much, ma'am. Thank you really from our heart. We would like you to be there online. We are now requesting Dr. Armina Fernandez and Dr. Shanti Bandhavadya, who have been our founders and foundation to run this NGO, to come and launch the package. To give a very brief background, Dr. Armina Fernandez has been a neonatologist and has served municipal operations and hospitals for more than 30 years. And then she started this NGO. Dr. Bandhavadya again has served the operation for 30 years as an anesthesiologist, head of the department, and they both have been, right from the beginning, have been involved in making this NGO and actually providing help to women and children. So I invite Dr. Fernandez, how do we hear you?
Package is getting packed.
Sure. Where? There. Yeah. Yeah, lovely. It's connected. Yes. Go to the room. Yeah. Which one it is? So to start exploring. Okay.
Thank you, ma'am. Thank you. Thank you.
Congratulations to all.
I would like to now call upon Vainatya Gavai and Bhavin, who will actually demonstrate the package live. Vainatya and Bhavin are from Siriti, who have helped us develop this package. I would also like to invite Sumit Bharat, who has been making films which can be embedded in the package. I would also like to invite Pundeep and Ravi, who has been putting our stuff on the website. So please welcome all, Vainatya. Please come. Vainatya, you can start.
Hi. So before I actually start going through the package, when the team at SNEHA came to us and said that we've got this content that we've put together, and they explained to us what they were trying to do, we were really, really excited to be a part of such an amazing project. And the first thing that we did after spending time with the team was we decided to spend some time talking to counselors. Because at the end of the day, the people who are actually going to use this package are the counselors, right? And it's very easy to take content and make it look good, but that's not the job here, right? The job is, how do I take this amazing content and package it in a way that it's easy for the counselor to get what they're looking for? So we realized very quickly that these counselors, they have the best of intent and the least of time, right? They all told us that we don't have the time. I wish I had 48 hours in a day to help the number of women who come to see me. They all said that mental health is important, but it's this fuzzy thing that they weren't sure about. They all said that they wish they could learn more, but they didn't have the time. So keeping all of this in mind, and there was a whole lot of other things as well, all these insights, we put that together to put and bring to life this content. I'm going to talk to you about maybe 5 or 6 key points that we kept in mind when we were building this package, and while I'm doing that, sort of take you through this. So as you can see, as soon as you kind of reach the platform or the package, it's not what you expect in terms of the seriousness of the content. It is very serious, very academic, very important content, but that doesn't mean that we have to make it look serious, right? Just because the content is serious, it doesn't have to look serious. So we've created these characters that basically take you on a journey throughout the content. So it starts off with, you can see on the left-hand side, well, yeah, on the left-hand side is the survivor, on the right-hand side is the counselor. This is actually a sort of version 1 of the package. We're actually working on a couple of really, really interesting animations that will also get integrated before it's actually kind of disseminated. So we have this friendly face that kind of keeps you company through this entire thing. Very quickly, on the first page itself, it tells you, just like Dr. Nyreen was taking you through it, what can you get out of this package? What is the larger picture? And then there's, of course, Garima, who is this person who is a counselor who's going to take you through this entire journey, right? Now, we realize that the way that counselors would consume this content is not start from the beginning and go to the end. It's not a book that is consumed cover to cover. There are some counselors who will skim through it, some that will say, I want to focus on this aspect, some that will refer to it when they're stuck somewhere. So the very, very important aspect is that it should be very easy to go from any point in the package to any other point in the package with just one click. And that's why you'll see that we've got this large menu, right, where this is basically the entire package, right? On a single screen, I can see everything that this package has to offer and very quickly jump to it. So that becomes one very, very key aspect. It's not a book. Think of this as more like an encyclopedia, right? You never read an encyclopedia cover to cover. You say, okay, wait, that's the topic I want, right? And of course, this is before the days of Wikipedia, when we all had physical Encyclopedia Britannica and whatnot that we used to go through. But now it's just a simple search. So anywhere to anywhere in one single click. The second thing that we've kept in mind, right, and I'm going to just now sort of click on any one, let's maybe start with Get Ready, is that we've kept the whole thing visual, right? We don't want reams and reams of content. We want that at every point, within a couple of scrolls, I get the larger picture and then I can go deeper. So for example, it says Get Ready. Very quickly, I can see a carousel of what are the different sections. If I want, I can just click on this to see all the different topics within that section. I think the internet is a little slow, but there's a little graphic that comes in front of each one of them, right? And then I decide which section I want to go into, right? So there you go, the graphics have loaded. So suppose I decide that, hey, I want to start with what are the basic counseling principles. As you can see, we've not made a list with, descriptions and points so that I have to keep scrolling and scrolling and scrolling. We've kept in mind that a lot of counselors are going to pull this up on their phone, right? So can you imagine if I have to keep scrolling to principle number 12, which comes after maybe 24 scrolls, right? That's just really, really painful. So at every point, we've started by saying, in the first set of scrolls, I will just see the principles. Now, I understand privacy, repo, I understand making it comfortable, but I want to know a little more about this whole thing, listen, right? So I click on that. It expands and it gives me more, right? So the entire package is structured like this, where every section has a broad overview and then I can go deeper into whatever I choose to. So that's the way we've kind of designed this content, which is mobile first and hierarchy driven, so that I can consume it and only look at the details of what I really want to consume at that point in time. So therefore, if you see, in terms of a UI UX, we're not creating, we've broken a lot of rules that you would see on websites, because rules don't matter, right? At the end of the day, if my counselor who's using this can see it and consume it in a quick way, to hell with all the rules, right? So we've changed that and kind of created it in a way that it's easier to consume. The other thing that I wanted to kind of touch upon is what they've again mentioned earlier is video, right? We know that video is the most engaging form of content, and a couple of videos have already been created, And as we keep building on this, as we keep adding more packages, there will be more and more video that will be incorporated. I'm going to show you one of the videos that have been incorporated and play that. So we are in consultation 2. I'm just going to hit play and then we can watch this. Oops, I think the audio's... Sorry.
डर एक ऐसी भावना है जिसका पीड़ित महिला अक्सर सामना करती है। डर विभिन्न प्रकार के होते हैं। पीड़ित महिला या तो अपने बच्चों को लेकर असुरक्षित महसूस करती है या फिर घर से निकाले जाने का भय महसूस करती है। उसे धोखे या बीच मझधार में छोड़े जाने का भी डर रहता है। एक काउंसलर के लिए डर के संकेतों को पहचानना महत्वपूर्ण है। पीड़ित महिला अपने डर का इजहार इन तरीकों से कर सकती है: कांपना, रोना, भ्रम, बेचैनी, पसीना आना इत्यादि। यह वीडियो काउंसलर को डर की शिकार हुई पीड़ित महिला को समझने और उसके साथ काम करने में मदद करेगा। काउंसलर निम्नलिखित तकनीकों का प्रयोग करेगी: सुनना, प्रतिबिंबित करना, पूछना, मान्य करना और रणनीति बनाना। सत्र 1। नमस्ते, यहाँ आने के लिए धन्यवाद। मुझे खुशी है कि आप मदद के लिए आगे बढ़े हैं। ऐसी स्थितियों से गुजरने वाली कई महिलाएं अक्सर डरी हुई रहती हैं, लेकिन आप इस वक्त सुरक्षित हैं। आप अपना डर हमसे बांट सकती हैं। क्या आप सोच सकते हैं कि अभी आपका सबसे बड़ा डर क्या है? मेरा सबसे बड़ा डर ये है कि मेरा परिवार मुझे स्वीकार नहीं करेगा। मैं आपकी भावनाओं को समझ सकती हूँ। जिन स्थितियों में आपको डर लगता है, तब आप क्या करते हैं? मेरा शरीर जम जाता है और मुझे कुछ समझ नहीं आता है। मैं समझ सकती हूँ। अगली बार जब भी आपको डर लगे, आप ग्राउंडिंग टेक्निक का इस्तेमाल कर सकते हैं। ग्राउंडिंग तकनीक आपका ध्यान मौजूदा स्थिति से दूर करने में और डर को काबू करने में आपकी सहायता करेगा। इन तकनीकों की मदद से आप निम्न कार्य कर सकते हैं, जैसे कि अपना मनपसंद गाना गाना, अपनी मुट्ठी को बंद खोल करना, गहरी सांस लेके उसे छोड़ देना, तेज स्वाद वाली चीजों को खाना। आगे बढ़ते हुए जब भी आपको अंदर से डर महसूस हो, आप इन तकनीकों का इस्तेमाल कर सकते हैं। अगले सत्र में हम चर्चा करेंगे कि यह तकनीकी आपको मददगार साबित हुई कि नहीं। सत्र 2। दोबारा आने के लिए धन्यवाद। पिछली चर्चाओं के बाद क्या आपकी स्थिति में कोई बदलाव आया है? क्या आप अपने डर को समझ पाए हैं? हाँ, बहुत खूब। अच्छा होगा कि आप ये अक्सर कर पाएं। कभी ऐसी स्थिति भी हो सकती है जहां पीड़ित महिला कहती है कि उन्हें सिखाई हुई तकनीकें काम नहीं कर रही हैं। ऐसी स्थितियों में काउंसलर उसे नई तकनीकों से अवगत कर सकती है। अगली बार आपको जब डर लगे तो आप यह 2 चीजें कर सकती हैं। आप उस स्थिति से अपने आप को दूर कर सकते हैं। आप अपनी मनपसंद जगह पर वक्त गुजार सकती हैं, या आप किसी ऐसे व्यक्ति की पहचान कर सकते हैं जो कठिन परिस्थितियों में आपका साथ दे सके। जरूरत पड़ने पर मदद मांगना जरूरी है। धन्यवाद। यह सराहनीय है कि आप इतनी दूर आ गए हैं। मैं आपसे अगली बार मिलने और आपकी प्रगति के बारे में जानने की आशा करती हूँ।
Can you hear me? Yes. So, this is just one of a series of videos that are being planned that will be integrated with the content. And I think that's basically what I wanted to talk to you all about, showcasing how we've taken a wealth of content and designed it in a way that's easily accessible, quickly accessible, on the phone, in a manner that anyone can use it the way they want to, right? This is not a prescriptive methodology saying you must do this in a particular way. It's what, I think when we've been conversing many times, I like to refer to it like a field manual, right? When you buy a new electronic item, there's the quick start guide and then there's the user manual. The quick start guide just gets you started. The user manual often is so complicated that no one wants to read it. This is something that falls beautifully in between, not too thick, not too time consuming, yet not too basic. It has depth and at the same time allows you to interact and consume it in a quick manner. So yeah, thank you.
Thank you, Vanatya. Simin, would you like to say anything? Yeah. Kuldeep? Yeah.
Hello everyone, thank you so much. And thank you so much to Team SNEHA for giving us the opportunity to work with them. And we are very proud to work with all of you, and we are planning to have some more kind of work so that we can contribute to the society, to our team members. Thank you so much for having me here. Thanks.
Thank you. Ravi, would you like to say something? So, thank you very much. Madam, are you there on the all? I would like to end over here and thank Honorable Madam and all the team members and people who worked to make this package. Thank you very much. Thank you very much, Madam, for your enlightening words. And we have a small tea break now, and then we can have the presentation from Sri Lanka, and we have our special guest speakers. Thank you.
So tea is being served this side, and we'll come here at about 12:45 again.
अभी किसका प्रेजेंटेशन है? श्रीलंका। मतलब खत्म हो गया इवेंट इतनी जल्दी? ये लास्ट है ना? इसके बाद लास्ट है ना? अभी हल्का लगा था आपको? तो अभी हल्का लगा था। सुनो ना, तो ये प्रेजेंटेशन यहाँ से करना है, वो बोलेंगे ऑनलाइन। प्रेजेंटेशन वहाँ से ही है। हाँ, जैसे। तो इधर आए हैं क्या वो? कहाँ पर है? परेशान कर पाएंगे रुको, मैं वेटिंग कर रही हूँ। हाँ कर लो चलो। चल रहा है वो शिल्पा के लिए, पकड़ू क्या उसको? शिल्पा इधर ही है।
नहीं मैं देखा, मैं कंफर्म किया। थैंक यू सो मच।
रिलैक्स।
हाँ हाँ दो ऐसे लोग हैं रिक्वेस्ट एक्सेस देते नहीं हैं दे एक्सपेक्ट अस टू वेयर इज दिस वन प्रार्थना वेयर इज श्रीलंका
टी ब्रेक दिलाय.
मुंबई फर्स्ट मधल्या 3 जणी येऊन बसलेत बघ.
कुठं आहेत?
सर्वात मागे सेकंड लास्टला त्यांनी हे केलं, एंट्री केली त्यांनी. आपण मेंटल स्ट्रेससाठी चांगला कार्यक्रम. ही मेन आहे साडी बनवायची.
Sorry, there's been a delay with the tea, but it's going to be here in a minute. And if we can start in about 10 minutes after that. Thank you so much. You're making the next presentation.
We are, yeah. So there's one of, well, actually, we need Krishna for this. We didn't send it through Google Drive. You sent it as an attachment in an email.
Yeah,
Yeah, because I don't want to mess up
I
somebody's
sent
laptop.
it to Prarthana and Krishna is on copy.
So it shouldn't be, sorry, Krishna. You,
So one.
प्रेजेंटेशन ना कि अभी लाइव नहीं है ना कुछ
Lojini is live, yeah? So Lojini is coming in live. Okay.
She has logged in and she logged
Krishna, we are having someone joining in live.
in line.
Yeah, that's okay, that's okay.
She is logged into the Teams account, no?
Yeah, she probably would have. Would have come through from Wamsa.
I believe this is the one.
That's
Yeah.
the one.
So you want to upload this one?
so if you go to a website called Flip,
Flip.
Also, then I kept some under.
Can I have some water as well?
I kept some there, one oral and chemistry and there. If you feel like you want help while you're present, you can take it.
I'll do it.
Because I'm scared of that. I focused one and I left it down.
Okay. Yeah. Okay. I'll be running it. Doesn't matter in terms of time. Okay. Yeah. Oh, okay.
story. So if you click on this and just set it to classic, eventually when it loads, it gives us the option to make it full screen when I'm ready to just give people a flavor of what it
Right.
looks like.
So I just wanted to ask you.
Yeah, it'll take a minute, I guess, to figure it out. Yes, sorry, Krishna. Go ahead.
Has Lojini joined on Teams? Yeah, she's there.
She's there.
I wonder if it's struggling since there's not great internet connection
No, there is a proper internet, 100 Mbps.
If you set this to a black background, that the contrast is good.
It's saying they are still converting. How many pages are there?
60.
16. It
But
shouldn't
for
be.
some reason, I mean, usually it's a little bit faster when we've played around with this the last couple of days. So I'm surprised that it's. What's the best way for this? We're going to use the PowerPoint.
Let me see.
And then briefly we were going to shift to this just to give people a flavor and then come back to the
Right,
PowerPoint.
just a minute. I'll help you out. Let me see if at all wants a photo book. No, not. I won't open in this. I'll open in Adobe.
That's what it looks like.
Yeah.
But it doesn't, I guess if you flip to the next page, it doesn't feel quite like a book, whereas on Flipsnack it feels like you're really
Right.
scrolling through it. But
I'll see if it is. Yes, it's uploaded.
आप मुझे बुला रहे थे
हाँ चाय के लिए.
so when you make this full screen, then you actually can click on the pages and it,
Right.
you know what I
right,
mean? It gives
Right.
people
Right.
a different feel. Anyway, we just basically
So
wanted
can
to
you?
give them a few minutes.
No problem. No problem. So let me do one thing. Can you write down the flow how you are going to present? present it, so it will be helpful.
Yeah, so Safia can, or
You have a pen?
got a piece of paper. So Krishna wants to know the
Order?
thing,
Order.
so she knows when to put this.
Okay, do you want a piece of paper?
Yeah.
Just give me this.
I don't
since
have
I
a
might
pen.
need those other two. Okay, there you go.
Do it at the end of me speaking. Is that what you want to?
Yeah, I think it's better. Yeah, that's better.
Yeah. Tell me.
So basically, I've got, someone Molly is speaking first.
Okay.
Then I'm speaking. And I just have 2 slides.
You,
And then
so
I'm going to show.
she has a presentation.
So she's talking through a couple of slides. And
There's
then
a
I'm
main
gonna
presentation that we sent yesterday night.
Yeah, that is there.
We're sort of sharing the slides in that, Krishna. It's a joint thing.
So,
Oh, okay. On YouTube, we can.
Well, I'm actually very privileged to get to meet you after 20 some odd years of having amazing organizations. It's quite a big deal for us. Yes. We'll carry the torch, ensuring the best as possible.
Thank you.
Till
28.
yes, we're going to try
Yeah.
on Sunday to go and have a nice look around.
Sure. Thank you.
bye, ma'am.
Thank you for helping me wait for a press.
We're still asking for ourselves, so. We can have the whole team actually.
Oh, are we doing a picture? Okay.
Yes, why not?
Yeah, Krishna, why don't you join us?
Okay. Thank you.
Yes. So, Alexis is going to present. It is the same presentation, right?
It's one PowerPoint that we're all sharing.
Right. One. So, Alexis and then?
And then I'm going to show this. So I'll
Okay.
finish with this. I've got like 2 slides and then I'll show this. And then I'm going to hand over to Pavati. Yes.
You have one colleague joining online, right?
Yeah.
She's already on.
Okay. Most complicated thing
Then?
for you all.
After,
So
after
then Lojini is joining from online.
That's Kavita.
Come.
And then Loji.
She is going to have a presentation, right?
She can screen share her presentation. But it will be the same thing that we are.
Ah, of course, of course.
She can screen share usually.
Yeah.
But if it's the same, why do you want her to screen share?
No, for the teams. So technically we'll help you. That's not an issue. You just let me know the flow. After Kavita, it's same presentation.
And then Safi.
Everybody gets it.
Okay, I'm just going to ask people to come back. Yeah.
Just gonna keep some water here.
Can I please request everybody to come back to the auditorium and take your seats?
Kate, I think we just better go sit. So we'll just sit here and be ready.
You can sit here.
Okay.
I will
Yeah.
mention that you're here.
Hovering to do ours.
Yeah, please sit. Please sit. Yeah. So that's the idea of having the chairs, for you to sit. तुम्हारा हो जाए तो I'll start the session.
Is it Rukmani?
Rukmini.
Rukmini, okay. Good. Nice to meet you. Thanks for
Likewise.
helping organize with Krishna. Yeah, so basically, someone Molly is just talking through those first slides, then I'm talking through mine, and then we'll shift out
I'm
of
going
this
to start the session.
Yeah.
Huh? Okay, can we please have everybody back? We would like to begin the last segment of the event. Can I request all of you to please take your seats?
We kind of cramped it to 20 because we thought if people want to ask us more questions about what our next steps are,
Okay.
they could do that. Okay. It should do.
Thanks. Okay, we will now begin the presentation by members of the VAMSA team from Sri Lanka. Can I ask somebody to please shut the door? So the noise doesn't carry inside. Thank you. Okay, the team from Sri Lanka, our colleagues are represented by researchers. There's Rasika Samanmali Thenekun, Alexis Palfriman, Kavita Vijayaraj, Lojini Shanmuganathan, who's joining us online, and Safia Riaz. I'd like to request the team to make the presentation of the package from Sri Lanka.
Good afternoon, last but not the least. Let me introduce our Sri Lankan team. Alexis Plefiman, she's a UCL Research Fellow and also the technical lead of VAMSA team in Sri Lanka. Kavita Virajini, she's the project manager in VAMSA team in Sri Lanka. Fatima Riaz, she's the project officer in VAMSA team in Sri Lanka. Miss Lojini, she's actually joining online with us today, and she's one of the peer researchers who helped us in this research work. Seeking comfort in everyday life. That's the study area that we went through with Sri Lankan team. And a visual exploration of youth mental health resilience in modern Sri Lanka. That's the study we mainly focused on. Okay, sorry for that. With all the background, our primary objectives for VAMSA Sri Lanka was to creative, flexible resources for professionals aiming to improve the mental health, adult women, and youth survivors of violence in Sri Lanka. Originally, we aimed to do this through qualitative research with adult women survivors and service providers in Sri Lanka, and a national survey on mental health and violence among adolescents. But then the COVID came, so we had to compromise our plan. But Keeping our target interest in youth mental health, we transformed our adolescent research into a COVID-safe project led by young researchers in Sri Lanka. Alongside, there were 21 young researchers who co-designed our study, lined with the mental health concern and curiosities. Using the power of photography and social research method, which is used in the social research method, we created a visual resource for young people and all those working with them to kickstart conversation about your mental health issues, coping in tough times, and what young people need more about the aspect of mental well-being and mental health support and spaces. Our photo book, Seeking Comfort in Everyday Life, visually presents originally data from 80 young photographers around in Sri Lanka on what nurtures positive mental health and habits and brings comfort in day-to-day life, their experiences. And our colleagues will discuss more about in this presentation. And we hope this book will remind us that how mental health is important in young person's life in nowadays. And also it is something that spark your imaginations to the possibility to promote well-being in the community as well. And this product, this photo book, will be available in all 3 languages, English and the other 2 local languages, and it will be available as a tool for anyone keen to open up discussion about issues impacting young life and creative in accessible way in Sri Lanka. And next, I would like to invite Alexis to discuss about the methodology of this study. Over to you, Alexis.
Can you all hear me okay? Ooh, that's quite good, isn't it? Let's see. On this one? Voila, okay. So, as Saman Mali said, we were actually tasked with producing a youth care package and an adult women survivor package. But COVID massively disrupted our ability to do the work at a national scale with young people. And so we completely reconfigured the work that we were going to do, and we decided to sort of hand over pretty much all the control to the young researchers that we had recruited and hired, so that they could tell us what their mental health concerns actually were, what were the issues that they felt were affecting young men and women in their age groups around different parts of the country, and then we let them design 4 different studies, that's the number of studies they chose to break into, to explore the issues that were considered pressing issues for them. So we had one overarching goal, which was to produce really contemporary, useful information that mattered to young people about their mental health in relation to violence, interpersonal challenges, and their mental health. And they chose to break into 4 teams. So we had a team looking at intimate partner violence, including in premarital relationships, because we have very, very little evidence on what's happening with young women before they get married. We had another team of young women that chose to focus on emotional violence in families, which is directed at girls in the household. And then we had teams that were kind of less overtly violence focused, but still focused on interpersonal challenges, which sometimes involved maltreatment and abuse. And that included looking at the impacts of COVID over the last couple of years in Sri Lanka, and also parent-youth dynamics. So the transition into young adulthood and how you're relating to your parents in that stage of life and the various difficulties that come with that transition and that maturing. And they spent time over 3 rounds building knowledge under each of these issues, sort of scaffolding the evidence over time. And in the end, we ended up with nearly 200 interviews, nearly 100 photographs and narratives, so interviews that happened around those photographs, and also short stories. So we mixed creative methods with more traditional methods. So what we're talking about now and today is actually just the photography output of this, which we have chosen alongside the young researchers to turn into an actual coffee table book or a photo book, which could be used in digital or physical form in different spaces. And the reason we chose photography is because none of us had ever used it before as a research method, and we were curious what it could do in terms of tapping into issues and trying to understand mental health from a youth perspective in a way that maybe having straightforward traditional interviews might not be able to do for us. And we also found that in COVID, of course, it was safe. It was something that was really easy for us to train people to do. Most young people in our team already had cameras in their pockets on their phones. Not necessarily all of the participants did, all of the other young people who participated, but we found ways of getting them access to a camera. And it literally helps us see mental health through the eyes of young people. So I'm just going to shift to actually giving you a feel of the book. It's not finished yet, but it's in prototype form. So I think Krishna's going to help us with that. Thank you. Thanks, Krishna. You can scroll through it a little bit if you want to. So this is the English version. It will eventually be trilingual. So we actually have spent a fair amount of time analyzing the photographs and then the conversational data that was collected around the photos. And what we did for that was to spend a lot of time with the photos themselves without any of the descriptions or any of the interview data that young people gave us. And then eventually we layered in those things, the titles that young people had given their photos and the interviews that they had talking about why they picked these things. And we have produced a book where we are summarizing each of the themes and positioning what we've learned about young people's mental health in Sri Lanka in the wider context of what's happening in young people's mental health in other settings. But the whole book will be available online. We'll make it available online, and then also physical copies for any organizations, youth groups, etc., that want to make use of this as a very non-threatening, lay, easy entry point to start talking about mental health. So Krishna, I'm going to hand over. You can step out of that. I'm going to hand over to Kavita to actually walk us through the findings of the photography work that we did.
Hi, everyone. Can we switch to the presentation, please? The other, through here. Yeah. Okay, so I'm going to very briefly walk you through some of the themes, 6 of the themes out of the 11 themes, and just show you a feel of some of the photos and some of the coping mechanisms young people resort to when they have a troubled mind or face challenges. So the largest theme you can see here is engaging with nature. So most of the photographs were nature related. And young people found this to be a strategy that they use to calm their mind down, to bring a sense of comfort and relief. And they felt that when their senses are stimulated, like you feel the sand on the beach, or like touching plants, they were able to gain comfort and relief. And the next one is relief through personal space. So as you can see, personal space is needed to reflect, to gain a sense of safety. So they spoke about how personal space was important for young people. And of course, this differed because for women, their personal space was within their homes and not more external spaces. So even the kitchen was seen as a personal space to feel safe and reflect. And then the bed, the bedroom, and even the paddy field. The next is companionship. And companionship is basically the comfort and relief young people gained by engaging, like taking care of pets, plants, and also having, interacting with family members, loved ones, and friends. So this was a method of coping and gaining relief and comfort. And the next one is livelihood support. So during COVID, a lot of young people lost their jobs and they were unemployed. And during that time, they had a lot of economic burden and mental stress because of this. And most of them said that, especially tourism, so I think this picture sort of represents the lack of tourism in Sri Lanka during COVID. And during this time, they said that they had resorted to traditional agriculture to gain economic stability. And when there is economic stability and they're able to provide for their needs and the needs of their loved ones, they were able to gain mental comfort. The next one is, of course, nurturing spirituality. In this, they encouraged and they said that it was beneficial for them to engage in religion, nurture their own spirituality, engaging in religion, praying, worshipping, meditating, and self-reflection through meditation had helped them gain some sort of mental relief during challenging times. And this is about investing in personal health and self-care. We had 2 young people who had fallen under this theme. So the first young person, she spoke about how journaling had helped her take care of herself and her mental health. To her, she named her journal Gulabo, and it was humanized. Her journal was her best friend, a companion. She wrote all her challenges, her sorrows, and shared everything on her journal. And she said she was able to increase her self-confidence and gain a sense of safety and comfort whenever she journaled. And the other participants spoke about fitness, physical fitness, and how it impacted his mental health positively. And he was basically referring to martial arts and how martial arts enabled him to express negative energy in a safe and non-threatening way, which later on had comforted his mental health. So I have taken you through the first 6 themes. My colleague Lojini, who is also a peer researcher, one of the young peer researchers who collected data, will join us virtually to take you through the rest of the themes. Krishna? Okay.
Can everyone hear me?
Yes, we can hear you.
Yeah, you can hear me, right? Okay, thank you. Hello everyone, I'm Lojini Shanmuganathan. I'm one of the community-based peer researchers in the BAMSA research group. And I also supported in co-developing this photo book. So I'm now going to quickly take you throughout the rest of the themes. So our 7th theme is comfort eating. Shall I share the screens, Dr. Alexis?
I think so, Lojini. Yes, if possible. I don't know if she can hear me.
Yeah, we can see your screen, so you can go ahead. We can see the slide saying comfort eating. You can go ahead.
Okay. So the 7th theme is comfort eating. So comfort eating or emotional eating was emerged as one of the themes which provided relief for young participants. Additionally, our participants clearly mentioned that how much they enjoyed having food, especially when they were when they are facing stress or facing any other problems like emotional instability, sorrows or anxieties and etc. And further, they clearly explained that they felt like eating the stress while they are having food, especially if they are under stress. Actually, young women in our team also clearly explained how much cooking delicious food and serving it with others has helped them a lot in creating new social connections. Further, it also has helped them to handle the people like who mistreated them. For example, like abusive husbands or abusive mother-in-law, the in-laws. So the next theme is nourishing creativity. So this is our most vibrant theme out of all our collection. So this theme was pretty successful in reducing the stress that the young people were undergoing. So normally being creative or being a part of creative activity helps a lot of young people to spend time in a productive way during the COVID-19 lockdown. And additionally, like also given them the opportunity to generate income. Furthermore, like some of the creative work normally requires a long time to complete. So completing such work has given immense amount of self-satisfaction and self-worth. Further, the young people also experienced, they were able to express more by drawing. Normally, but they can't express through the words. The next theme is leisure. So leisure again emerged as one of the popular themes among our young participants. Normally, like being a part of social media, creating memes, like watching YouTube videos, were pretty popular among our young participants. So now listening music or watching YouTube videos has helped them a lot to switch their focus from the problems they have. Additionally, it also has helped them the problems they have, and additionally it also helped them get rid of the stress they were undergoing, and to get rid of the loneliness they were feeling during the COVID-19 lockdown period. And additionally, like reading memes and watching comedy shows has helped them to laugh, eventually has helped them to unwind the stress. And the next theme is travel. So Sri Lanka being a popular travel destination, travel was emerged as a pretty popular theme among our young participants. So travel has given them the opportunity to take regular breaks from their routine monotonous life, and also given them the opportunity to understand that problems are both from everyone and not specific for one person. So this kind of understanding has helped them tackle problems that they were facing in a better, efficient manner. Additionally, for young women, traveling has helped a lot. Most of the time, young women, they don't spend time for themselves. So while traveling, it has given them the opportunity to have their own personal free time, which has helped them to regenerate themselves a lot. And the final theme is drawing on hope. Hope emerged as another source of comfort and relief for young people, which has helped them to overcome difficulties during the pandemic time and during the other life challenges and failures. So normally the real life stories help them a lot, to gain confidence and courage to tackle their problems in an efficient way. Additionally, it also has helped them to reach success. So that's all about the theme. Thank you very much for giving the opportunity, and now Safia will take over further.
Hello everyone. I'm just going to make this a bit short person friendly. Hi, I'm Safia. So I will basically, hi, I'm Safia. I'll be taking you all through the next slide in terms of the way forward.
Use the slide pointer.
Okay. In terms of the way forward, both as we envision it for our photo book and also in terms of our care package. So basically, I think as a core team, we were quite surprised as to the amount of depth and nature that we were able to generate through this photo voice activity. Because what we learned was that it not only served as a purposeful and useful activity, but it also served as a launch pad to have very often complicated and often sensitive conversations. So what we believe is that this form of activity can actually be taken forward and extended to even GBV and in terms of mental health and youth violence, and to have basically conversations and as a conversation starter. In this specific research, basically, we not only found out about the coping mechanisms that young people used, but also about the life stresses and challenges. So in terms of heavy workloads, in terms of endless targets, as they called it, for education, employment, personal achievements, and so on. So to us, this photo book is a conversation starter that young people can actually build on to get the conversation started, basically, about mental health challenges and also about how they can manage life stresses. So anybody can basically pick this up, from youth themselves to friends, to people who are working with youth networks, to draw on some of these collections as inspiration to maybe then try on within their own circles. And I guess more ambitiously, we are hoping that some of these collections could then be incorporated into formal mental health, social, and educational services. And we're actually hoping to work with some of the community researchers in the coming months and in the next year to kind of have dissemination activities in terms of exhibitions, in terms of road shows, and so on. Apart from this, coming back to the care package, which was also another big part of our aim and a big part of our research. While we haven't really gone into depth about this specific resource today, we would like to share a glimpse of it as we've presented on the screen. Basically, this resource has taken the shape of a workbook, a practical workbook for non-mental health specialists who provide early support or early stage care for women survivors of violence. And why we have chosen non-mental health specialists was because while we were having these conversations with women, what we realized was, at least in Sri Lanka, the first point of contact was very often a non-mental health specialist. And we felt like maybe that gap needs to be addressed. So as you can see, I think coincidentally to what SNEHA had also proposed, we have also taken a storyline approach where we follow a narrative between a service provider, as in the picture, and a survivor. And I think what our thought process was to kind of take the service provider through the process and give an understanding that the process of care is not always linear, and there are always setbacks in how we can practically, I guess in a workbook style, kind of manage that and go on about it. So apart from that, we are also working on an adolescent resource, we are also working on building a more comprehensive picture of adolescent mental health. So post-September, we've actually collaborated with UNICEF to conduct a national survey in order to collect adolescent mental health information that we can then maybe hopefully in future adapt such a package for youth mental and youth adolescents in Sri Lanka. Thanks a lot for giving us your time. Thank you to SNEHA for giving us the opportunity to talk. So thank you.
Thank you very much to all our colleagues from Sri Lanka. What we'll do now is we'll invite our special guest who's joining us online. It's Claudia Garcia Moreno. I don't know if she's online already. She's there. Welcome, Claudia. We look forward to your comments on the package of care that has been launched today. Just to introduce Claudia, Claudia Garcia Moreno is a very well-known figure in the field of gender-based violence. She has collaborated with many teams across the world and is currently at the Department of Sexual and Reproductive Health and Research of the WHO. Over to you, Claudia.
Very much, and good morning, good afternoon, everyone. I was expecting my corporate WHO background to appear, but I don't know exactly. happened to it. I want to start by just saying how pleased I am to be able to share in this important milestone for VAMSA and to witness the launch of these packages of care for mental health for violence against women survivors. I've had the privilege of being on the advisory group of VAMSA and have really enjoyed the limited involvement that I've been able to have. And primarily it's been great to be able to meet many wonderful people committed to addressing mental health and violence against women. These are two issues which are very central to the work that I have been privileged to lead at WHO, and also very dear to me personally. So really delighted to be here. I'll be brief. I'll recap a couple of things that have already been said. David already referred to the most recent estimates on prevalence of physical or sexual intimate partner violence and non-partner sexual violence, which WHO published early last year. And as he mentioned, I mean, we find that still, 10 years after the first estimates that we produced, nearly 1 in 3 women over 15 years of age are affected by either one of these two forms of violence. And within that, we know that the most prevalent is the violence that happens in the home, primarily from intimate partner violence, but also, as we know, from other family members. And here the global average was 27% for women over 15 for just physical and or sexual intimate partner violence. But this global average hides really very big differences. We see much higher rates in lower and middle income regions and countries compared to high income countries and regions. But also we see countries, particularly those affected by conflict, with much, much higher rates, even reaching as high as 1 of every 2 women being subjected to this violence. So the rates are shockingly high, and South Asia, alongside Sub-Saharan Africa and the Pacific Islands, are among the highest prevalences. So this work is really important. And one thing I was really delighted to hear from Sri Lanka about the focus on youth, because I did want to flag that this violence starts very early in the lives of girls. Our data found that nearly 1 in 4 of adolescent girls aged 15 to 19 years who have had a partner already report being subjected to physical or sexual violence by a partner. So this is an age group that we need to pay very important attention to. And obviously for us the focus is girls, because they tend to be the victims, but as mentioned by Madame Rajiv Lochan, we also need to really focus on working with adolescent boys, because this is an important time in development of relationships, and in terms of prevention, it's very important to look at this age group. We know also that this is an age group that has been strongly affected by COVID, and we've seen that very eloquently from the presentation from Sri Lanka. So very, very delighted to see this focus on adolescents. And also I noted that SNEHA had a focus on adolescents, so very, very pleased to see this. It's already been mentioned also that there are very strong connections between these forms of violence against women and mental health, and that relationship is complex, it's bidirectional, and yet these issues are barely mentioned in the training of many healthcare providers, including mental health care providers. So the work like that VAMSA has been doing, that many of you do in the context of your NGOs and your organizations, is very important in this regard. We also have been working from my department with colleagues in the WHO Mental Health Department to develop a package for mental health care providers, not dissimilar to those that we have heard about today, but obviously more global and with a focus on emergency settings. And really delighted to see how much this work has progressed, to see the packages out there, and obviously we will build and integrate as much as we can into our current draft and ensure that we create synergies as we go along. There's big gaps, particularly in capacity building of providers, and so there's a lot of work to be done, and sharing in this work will only enhance it. So I'm very much looking forward to getting into Garima and seeing some of the other packages, Sangat and other packages in more detail. I think the third thing I wanted to mention was also a challenge that Rukmini mentioned at the very opening, about how these issues, both violence against women and mental health, have been really very silenced, very marginalized and stigmatized. And this is beginning to change. I think we have seen some important changes in the past, years, but we still have a lot of work to do. I mean, much of this change is due to the long-standing advocacy of many women and feminist organizations that have brought attention to violence against women, organizations like many present in the room to bring attention to mental health. And more recently, I think it's really important that we're bringing attention to the intersections between these two issues. There's been a couple of other initiatives that I want to mention in this regard, recognizing that, of course, there's still a lot more to be done. Just a few months ago, the Lancet Psychiatry Commission there was a report issued by the Lancet Psychiatry Commission on intimate partner violence and mental health, which brought attention to some of these issues and highlighted the importance of transforming mental health policies and services to address some of these issues and to really increase the understanding and awareness of mental health care providers. So I think these packages and the work that you have been doing, the systematic reviews and all the other work, really are important foundations to support this work. WHO has also been highlighting the importance of mental health with a slogan on no health without mental health. And in June, we launched a report on a mental health report, Transforming Mental Health for All. And this report, I think, makes important strides in a couple of areas that are related to what we are discussing here. It recognizes that the needs in mental health are many, but yet the responses remain very inadequate and often lacking, insufficient. It also highlights that stigmatization and social exclusion are exacerbated in contexts where services and support for mental health are not available. And lastly, and very important for me, because I'm the little drip advocate on these issues, it identifies sexual violence and intimate partner violence as important drivers of mental health problems, particularly among women. So, and we know that those facing partner violence face a double stigma. It takes a lot of courage for women to disclose. And sometimes when they disclose, they face reactions like, you must have done something to deserve it, or, what do you expect? This is part of marriage, this is part of married life. So at the same time that we're building the specific skills on mental health, we need to be addressing the broader culture of acceptability and even sanctioning of violence against women. Because unfortunately, sometimes these kind of remarks also come from healthcare providers themselves. So I just want to end by saying, we have now some tools that we didn't have when this work started for us a couple of decades ago. We have the Sustainable Development Goals that recognize the importance of addressing violence against women and girls and other forms of violence as part of development and health. And we also have a global plan of action that was endorsed by the World Health Assembly in 2006, highlighting the role of the health sector in the context of a multi-sectoral response in addressing violence against women and girls. So we have some political tools also that help us to engage with ministries of health. And my last point, and I'll end, is that this important contribution that the work of VAMSA is making to the field and to addressing some of the gaps we still see in the availability and the quality of support services needs to be scaled up. It needs to lead to changes in policy at the bigger level and to practice, not just among those who have been involved with developing these tools, but beyond. So I really encourage you to continue to advocate with governments at all levels, as you're already doing, and look forward to being able to collaborate and support efforts like this, which also support the broader work of strengthening the health response, and eventually also ensuring that survivors have, that these changes happen where it really matters, where survivors are, where they're seeking services, and in the countries that you're working in. So thank you very much, and congratulations to all those involved in this work, and really looking forward to getting into those packages in detail. Thank you.
Thank you very much, Claudia. I would like to now call upon Dr. Delan Devakumar. He's the principal investigator of the VAMSA group, to propose a vote of thanks. Delan is joining us online. He is Associate Professor in Child and Adolescent Health at the Institute for Global Health, University College London. He's also an honorary consultant in public health in the Global Health Division of the UK Health Safety Authority. He's co-director of the UCL Centre for Health of Women, Children and Adolescents. He's online.
Thank you very much. And can I start by apologizing that I'm unable to be there with you today. I was very keen to join, but unfortunately with a visa issue, I couldn't travel. So I'd like to give a vote of thanks to several people. This has been a wonderful event so far, and I've been listening from early morning. It's great to hear the different pictures from the different groups, and some of the details about SNEHA as well. So could I start by thanking the whole VAMSA team? There are many people in many organisations across India, Sri Lanka, Afghanistan, and also the UK. And Professor David Osdray gave a list of those at the start, and I'd like to thank the whole team for all the involvement over the several years we've been working with this. Next, I'd like to thank SNEHA. SNEHA has led this event, done all the background work in organising this event. Can I start by thanking some of the senior members, Vanessa D'Souza, the CEO, to Shanti Pandavadi, the Executive Director of SNEHA, Dr. Mila Fernandez, Founder Trustee, all the other trustees, Program Directors, Associate Program Directors at SNEHA. Every organisation has a huge number of work in the administrative side. And so thank you to the human resources people, the admin, finance, IT, MD support people in SNEHA, and then all the counsellors and counsellors of the organisation. Thank you to our special guests, Mita Rajagloch, Claudia Garcia Moreno, who spoke, also Malati Iyer, who wasn't able to attend, unfortunately. Thank you to the team at the YB Chavan for organising this event. And as I mentioned, I'm very sad to have not been there. Just the everything. And then thank you to all of you, all the participants who attended. Please do engage with members of the team and talk to them about your own work and how your work might fit in with the packages that have been presented today. We do hope to engage with all of you, with those organisations. And thank you, finally, and it's most important, to all the participants in every location, in all the consultations and all the workshops that have been conducted throughout the process, to the survivors of violence, to the counsellors and service providers as well. We couldn't have done any of this without your support and help throughout the years. And we hope that the work that's been developed will be useful to everyone who's been involved so far and to all the other people going forward. So thank you very much, and I will hand back to I think the community of the SNEHA team.
Thank you, Dylan. And we will now close this session, but not without lunch and not without another word of thanks to all of you for being here with us through this entire morning. So please do join us for lunch on the 4th floor, and we will continue to network and speak to each other over there. Thank you.
close for a second.